I teach on 3 days, 4 days no classes. I was thinking I may also get if your university needs extra teachers, I can teach there.
Oh, yes.
They need.
I don't know, but you should come.
Yeah,
Because I would prefer having you
yeah.
come.
Internal medicine, I teach best.
You can actually, because now they always have all these Chinese teachers who are all doctors
Uh,
working in the hospital.
internal
So maybe
medicine.
if you approach them for it.
Yeah, it
Because
is.
we're doing internal medicine now.
Okay, okay.
It would be very good to have you
Yeah,
there.
it is all about. I know they need teachers always, but it is about how to approach them, who to approach.
There
That's the
are
problem.
a few really good
Yeah.
who are doing the
Okay. What's the name? No, I haven't heard. Contact. Okay. Okay. You also can talk with him.
yeah, yeah.
If they need extra teachers, because I'm free, so most of the time in the afternoons, every day I'm free.
Everyone would really appreciate it.
Yeah. So we already covered adrenergic and cholinergic. I will review that. So I will cover that in the end. Okay. So let's first cover sedative, hypnotic, and anxiolytic drugs. So first drugs are benzodiazepines, barbiturate, and alcohol. So now these drugs. Okay, first you open your page. Okay, these drugs cause dose-dependent CNS depression. So at lowest dose, what they cause? Sedation and anxiolysis. At very low dose, they cause paradoxical disinhibition. Okay, this is why some people, who drink a little alcohol, they become more social because they cause paradoxical disinhibition. They disinhibit your mind. They open your mind. But as you go, they cause sedation, anxiolysis. You go little higher, they cause hypnosis, and then anesthesia. Means this is anesthetic dose. What if you go above anesthetic dose? If you give too much anesthetic, too much of any of these drugs, especially barbiturate and alcohol, what will they cause? Medullary depression. Now, what does medulla control? What does medulla control? Respiration and cardiovascular system. So, what will happen to patient? He will die. Okay, so you see too much alcohol, some patient die. Okay, too much barbiturate, some patient die. Okay, but what about benzodiazepine? It reaches a plateau. Okay, does benzodiazepine goes beyond this coma and death? No. So an overdose or toxicity of benzodiazepine, can it kill? No. So benzodiazepine, if someone takes too much benzodiazepine, he can sleep a lot, but he cannot die. But what about barbiturate and alcohol? They can kill because benzodiazepine reach a plateau and do not go beyond that. Okay, that is very important. So barbiturate overdose and alcohol overdose can kill. So you understand this dose dependent effect, okay, and especially important this benzodiazepine, okay, because this is a plateau, it cannot go beyond that, so it cannot kill. But other drugs, barbiturate, alcohol, they can cause medullary depression, coma, and death. Now, what is their mechanism of action? Their mechanism of action and that they open chloride channels on GABA complex. So GABA is the receptor for these drugs. But you see each one has its own binding site. For example, GABA binds at alpha unit. Benzodiazepine binds at gamma unit. Barbiturate binds at beta. But do you need to memorize this? No, just to understand that each one has its own receptor. No need to memorize. Okay. Yes, USMLE is not about memorization, it is about understanding. How do you activate any nerve? Do you depolarize or hyperpolarize? Means how you activate a muscle or nerve. You need to cause depolarization or hyperpolarization. Depolarization. So what will happen if you cause hyperpolarization? It will be activated or difficult to activate. difficult, and these drugs, this is what these drugs cause: hyperpolarization. But there are two mechanisms. Either, okay, chloride means it is negative charge should come inside, or potassium should go out. In both cases, what will be inside? More negative or more positive? If chloride influx, chloride enters a cell, or potassium leaves a cell. Potassium is positive charge. So what will happen if positive charge leaves a cell? So inside will be more negative or positive? Negative, and this is what we call hyperpolarization. In depolarization, you see inside of a cell becomes more, inside of a cell membrane becomes more positive. Okay, so you have two ways of causing hyperpolarization. Either negative charge should go inside, or positive charge should go out. So GABA A has means in that chloride channel, chloride goes inside, but GABA B, potassium, goes outside. Okay, if you know the mechanism that they activate GABA channels, and the mechanism is a hyperpolarization, then you need to pay attention to these words: benzodiazepine. Benzodiazepine, you need to know, pay attention to this word. It potentiates GABA, means it makes GABA stronger, so it increases frequency. Okay, if you go and look at barbiturate, it prolongs GABA activity, and it prolongs means it prolongs the duration of chloride channel opening. But it increases, it doesn't prolong, but it increases the frequency of chloride channel opening. Okay, you understand this? Frequency means many times, duration means how long it is open. So this small thing you need to understand. And they have no GABA mimetic activity. Means benzodiazepine themselves has no GABA mimetic activity. But what about barbiturate? They have GABA mimetic activity at higher doses. For example, at a higher doses, benzodiazepine, can they act alone? No. This is why if you go previously, they reach a plateau. But at a higher dose, barbiturate can open GABA channels by themselves, because they have a GABA mimetic activity. This is why alcohol and barbiturate. You see, this is why alcohol and barbiturate can cause medullary depression, coma, and death. Is this clear now? So that is a small difference. Potentiation, increase in frequency, no GABA mimetic activity. Okay. Barbiturate, they prolong means duration, and they have GABA mimetic activity. So will USMLE ask these small things? No, USMLE is not about small things, it is about concept. So USMLE will not about potentiation, prolong, but USMLE will ask about concept. Okay. And these receptors, they act through busy receptors. Busy receptors are part of GABA complex. Again, you have two type of busy receptor: busy 1 and busy 2. Do you need to remember these subtypes? No, because USMLE is not about memorization, it is about understanding. Later on I will tell you why this subdivision is important, because we have separate drugs for busy 1 and we have separate drugs for busy 2. So in older drugs, we have, older generation iPhone, older drugs, they act on both receptors. For example, if we want to give them for anxiety, what problem they will cause? Sedation. Patient will be sleepy all time. Okay. If we give them, for example, sleeping, these drugs can be used for as a sleep drugs. They can be used as a anti-anxiety. If we give them anxiety, for example, I take it now, I'm anxious, but then I will feel sleepy all time. I cannot work. But on the other part, what if we give them for sleep, sedation? Then they will cause a cognitive problem. In the morning you go to office, you are still feel sleepy. Okay. So we have now new type of drugs. New type of drugs means next generation drugs. They work either on busy 1 or busy 2. Okay. As we are becoming more technological, we do more research. So if you use a drug for sleep, which receptor should stimulate? Busy 1 or busy 2? Busy 1. Okay. So that drug is zolpidem and zalplam. Have you ever heard about it? Okay, I will, they are coming next. Okay, so they the barbiturate do not act through busy receptors. They have their own binding sites on GABA A complex. Okay, and also inert complex 1 of electron transport chain. If you have studied biochemistry, barbiturate also inert complex 1 of electron transport chain, but that is in biochemistry. So these are drugs. Any drug that ends with zolame, especially arzepam, they are benzodiazepine, temazepam, alprazolam, anxiety, sleep disorders. So most of them are metabolized by liver to active compounds, except for which drugs? Oxazepam, temazepam, and lorazepam. How will you remember them? You have to make it easy to remember. What about LOT? LOT. Okay. Except lot drugs. What are lot drugs? Lorazepam, okay, oxazepam and temazepam. Okay, when you have to memorize something, make it is easy. So any drug that has a very long duration of action, such as diazepam, what we use them for? Anxiety, muscle relaxation, and withdrawal state I will teach you later on. But if any drug has a very short acting, we use them for what? Very short acting, we use them for means anesthesia, that is midazolism. Temazepam, oxazepam, they are used for sleep disorders. Okay, lorazepam, it is used for IV form, is used for epilepsy. What about anxiety, panic, and phobias? Panic and phobias are for short period. Okay, so for them, which drug we will use? Alprazolam. But are you tested these drugs individually? No. Okay, you have to remember as a group. As a group, all these are benzodiazepine. Okay, and very short acting, that is midazolism, and after that a little more short acting, such as temazepam, oxazepam, they are used for sleep disorder. And diazepam, it is very long acting, so it is used for withdrawal status, and lorazepam is also used for status epileptics, because when someone is status epileptics, we have to use a drug IV, and lorazepam can be used IV. We cannot use midazolam, it can also be used IV, because midazolam is a very short acting. I'm explaining these, but USMLE doesn't care about these small things. Okay, because if USMLE wants to ask about benzodiazepine, it will give you 5 choices, A, B, C, D. Out of 5 choices, one will be benzodiazepine, other will be other choices. It will not tell you A, B, both are diazepam. No, USMLE is not about small things. It is about big picture. So, will you use these drugs for sleep disorder? In USA, what is best drug for sleep disorder that is available over the counter? And diphenhydramine. Okay, I will cover that. This is antihistamine. Okay, if you have to use, someone is really sleep problem, you cannot use this, because they act on both BZ1 and BZ2, and these are older generation drugs. So means what are these use for anxiety? Also we have now new drugs. This is older drug. For anxiety, which drug we use? They will come later on. So what are their uses left for? Midazolam is used for anesthesia, because it is good. Epilepsy, not epilepsy, only status epileptics. You know about status epileptics? I am covering this in epilepsy chapter. Okay, later on. And so what are their uses? Withdrawal status and muscle. Epilepsy means someone is having epileptic attacks, seizures, but those seizures continue for more than 30 minutes. When someone has seizure, we give some drug, seizures stop. But what if seizures don't stop and go beyond 30 minutes? Then what we call that? Status epileptics. Should a patient be seizing for 30 minutes? Why? If patient is seizing, means the respiratory muscles are also seizing. Can that patient breathe? No. And if ask patient, means patient has seizing, patient has breathing problems, means hypoxia, and neurons. Neurons are very sensitive. If they don't get enough oxygen, these cells die, and that patient can have permanent brain damage. Okay, so this is why this is one of the best drug for and first line drug for status epileptics. So what are their uses? For panic phobias, will you use these drugs? We have better drugs. For acute, you can use because alprazolam is short acting. But chronically, can you use these drugs? No, because they cause sleepiness, sedation, and they cause cognitive problem. Okay, so what are their uses left with? Withdrawal state. I am coming to that later on, and state is epileptics. For other disorders, we have better drugs. Okay, so please pay attention to these things. So uses of barbiturate. Now phenobarbital is used for seizures. It is used for epilepsy. Okay, thiopental is very short acting and it is can be used IV, so it is used for induction of anesthesia. What is induction of anesthesia? To put a patient in anesthesia. We have drugs for induction of anesthesia, then we have drugs to maintain anesthesia. So because this is short acting, so can it be used for maintenance of anesthesia? No, it can be used only for induction. They are metabolized. Remember from first chapter, what were general inducers of P450 system? Anti-seizure drugs. One was phenobarbital, other was what? Phenytoin. First chapter that I covered last time. So they are metabolized by liver, but which system? P450 system. And any drug that induces P450 system, they are contraindicated in porphyrias. Have you covered porphyrias in biochemistry? This is very important because I cannot cover porphyria here because it is a biochemistry topic. Okay, so anyway, right now remember it when we get some chance because you already covered biochemistry, so I don't know I will be able to teach you that or not. So in porphyrias, P450 system is this is contraindicated. You can go to biochemistry and read on your own why it is contraindicated. So tolerance to and dependence on sedative hypnotics. Chronic use leads to tolerance. What is tolerance? Now some people initially think, oh, this is just one cigarette. I'm not user to smoking too many cigarettes. So initially he uses just one cigarette, but over the time, he becomes tolerant to that one cigarette or one glass of alcohol. Then why? Because now he is not getting the same kick, the same effect from one glass of alcohol or one cigarette. Now he needs two cigarettes. After 2 or 3 months, he again becomes tolerant to those two cigarettes. Now to get this, because his body becomes used to it. Okay, his body becomes used to it. It becomes tolerant. So now he need three cigarettes. So that is known as tolerance. Over time, he will become what? Psychologically and physically dependent. Now we call it abuser. Okay, means drug abuser, means alcohol abuser. Chronic alcoholic. So what is psychological and physical dependence? Psychological dependence is means even though you have no physical dependence, but you mentally means can't do anything until you get that drug. Sometimes if you can't cigarette, you mentally not feeling okay. That is psychological dependence. What is physical dependence? Physical dependencies means you can, if it is chronic alcoholic or heroin abuser, if they become initially, they ultimately they become psychologically and physically dependent. Now, if they don't get drug, what they have? They have rebound symptoms because they are physiologically dependent. Means you are when you drink coffee daily, your body becomes dependent on caffeine. If you don't drink coffee, what you get? Headache and these things. You can't work. Okay, but caffeine is not that much addicting, but these drugs are really very addicting. Okay, they have abuse liability. This is why we don't prescribe benzodiazepine for sleep because they have abuse liability. Same for barbiturator. What are withdrawal signs of benzodiazepine? What we use them for? We use them for sleep and anxiety. So the withdrawal symptom will be same. What will happen? Okay, if someone someone is chronically using antihypertensive drug. What will happen if he suddenly stops that drug? His hypertension will shoot. Okay, so when you use a drug chronically, you should not stop that drug abruptly. You have to taper it slowly. So withdrawal signs are same with rebound and means insomnia, anxiety, and what we use them for, seizures. Okay, patient can either, when these drugs were used for anti epilepsy, now you stop it, that patient will have seizures. So should you stop them suddenly? Never. Okay, now withdrawal signs are barbiturate and ethanol, of course anxiety and agitation. But with alcohol, what you see? Life threatening seizures, and we call them tremors, delirium tremors. Not only seizures, but that patient will have delirium hallucinations, as elephants in room, or there are snakes on my skin. And they give you classic case in USMLE. Someone is admitted to the hospital. In hospital, can they get alcohol? No. In hospital, most patients, when you admit, they lie. They say, oh, we are abstinent, we don't use alcohol. But exactly after 42 hours, he suddenly starts having seizures and means hallucinations. What choice will you pick? Alcohol. Patient is having alcohol withdrawal symptoms, signs and symptoms. For any kind of withdrawal signs and symptoms, what is best drug? We just covered it. Diazepam. Okay, will you give them alcohol or diazepam? What is management of withdrawal? Supportive and long-acting benzodiazepine. What was long-acting benzodiazepine? It was diazepam. Okay, diazepam is a long-acting. For withdrawal symptoms, you will give short-acting or long-acting. You have to use a drug that should work for long-acting. Okay. Will you use benzodiazepine for anxiety and sleep? No. Pharmacologically, you can use, but now we have better drugs. Okay. So because they have abuse liability, you become addicted to them, and plus they cause cognitive problems. If you use for anxiety, they cause sleep problems. You know, you must have almost celebrities. They overtake overdoses of drugs and they die. Even Michael Jackson and many. Why? Because they take multiple drugs that have CNS depressant effect. Maybe they are using heroin. Along with the heroin, they are also drinking alcohol. So what are those CNS drugs? Anesthetic, antihistamine, opiate, beta blocker. Beta blocker is also CNS. So if someone is using opiate, now he has cold, you are giving antihistamine. Are already using opiate, now he is also drinking alcohol. Okay. Do you watch TV serial Dr. Rush? In this week's program, there was a problem of overdose of opiate. He was close to death, and so means anyway, you never add two depressants together because their effect will be additive, and they can cause medullary respiratory depression. And what barbiturates do? They induce metabolism of which system? First chapter, P450 system. So what they will do to other drugs? You know, P450 system, all lipid soluble drugs are metabolized P450 system. So if barbiturate induced P450 system, means our P450 system is more active. So what will happen to these drugs? They will be metabolized very quickly. So will do their effect? No. If you are giving someone for warfarin for anticoagulation, so will warfarin work? No, that patient's blood will coagulate. Okay. So non-busy drugs. So you see, I told you that benzodiazepine drugs we nowadays don't use for sleep and sedation, anxiety, because we have better drugs. What are those better drugs? Zolpidem and Zalplan and Buspirone. Look, Zolpidem and Zalplan are the benzodiazepine drugs or non-benzodiazepine? Non-benzodiazepine. Through which receptor they act? BZ1. And what was job of BZ1? sedation, sleep. So you use them for sleep, so they have less effect on cognitive. They are used in sleep disorders. Is there any tolerance or abuse liability? No. What about benzodiazepine? Benzodiazepine, they have tolerance and abuse liability. Pills. Benzodiazepine also act on BZ2 receptors. They cause cognitive problem. So which drug for sleep you will prefer? Zolpidem and Zalplan. I used both, means benzo and zolpidem, but zolpidem is way better than, because that cause cognitive problem and complications. Okay, so zolpidem is better if you want to use drug for sleep, even if for prescribing. Okay, so this is uh, and then buspirone. Buspirone, does it act on GABA receptors? No, it acts on serotonin, but it is a partial agonist. Partial agonist means, can it 100% open serotonin receptors? Remember from chapter 2, partial agonist only activate receptor 50%. Because 100%, if it is a full agonist, it again will have bad side effect, such as seizures and these things that will occur in future chapters. So what is used for? Generalized anxiety disorders. You see, when someone is generalized anxiety, what is generalized anxiety? You know, some people are anxious about everything. They have to attend class every day and they are just anxious. Okay, they have exams. Before exams, they are anxious. They have to go for shopping, and before going shopping, they are anxious. Means they are anxious about everything. Generalized anxiety disorder. In that case, which drug you will use? Buspirone or diazepam? Benzodiazepine. Why? Because if you give them benzodiazepine, patient will feel sleepy all time. So you see, buspirone is a non-sedative, but and it takes 1 to 2 weeks of effect. So if one has a generalized anxiety disorder, means now we have to give a drug that should be long acting and non-sedative. So what is best drug? Buspirone. What about someone has a phobia and panic disorder? Phobia and panic disorder, are they longer means duration disorder or short duration disorder? Panic disorder. You have panic disorder and it just disappears in 20 minutes. They are very short acting. Panic disorder. Okay. You just get in elevator, you feel panicky. Very short acting. In that case, you need a short acting drug, long acting drug. In that case, you can use benzodiazepine, alprazolam, short acting. Okay, why? Because that is short acting and this is not chronic. You will not have to use benzodiazepine chronically. You will have to use a drug for only short time. So whenever there is an overdose of benzodiazepine, which drug will you use? What is antidote for it? Flumazenil. Okay, so any overdose, okay, benzodiazepine, which drug you will use? Flumazenil. Can flumazenil is the flumazenil antidote for barbiturate and alcohol? No, it is only for benzodiazepine. And flumazenil also works for zolpidem because it is BZ1 receptor. So what is antidote? If someone, sometimes these are sleep drugs. Some patients take a whole bottle to commit suicide, but will they die? No. I already told you benzodiazepine cannot kill. If you want to frighten your family members with suicide and don't want to die, which drug you will use? Okay, benzodiazepine. Because you will be asleep for 3 4 days and all your demands will be met. So will you take barbiturate to frighten your family? No, so don't do this, okay? Got this? New trick. So now next chapter, alcohol. All alcohols cause CNS. We already covered that alcohol works through which receptor? GABA. And all alcohols cause metabolic acidosis. You see, in their metabolism, what is the end result? Oxalic acid and formic acid. So, what is the usual alcohol that we drink? It is ethylene glycol, methanol, or it is ethanol. Ethanol. Okay, ethanol is metabolized to what? Acetic acid. You know, all alcohols are metabolized to acid. Acetic acid can be metabolized in our body. But what about oxalic acid and formic acid? Can they be metabolized in our body? So what will happen if they accumulate in our body? Death. Okay. And in our countries it is very common. In India, you know, in Germany, in marriage parties many people drink alcohol and they die. Remember what kind of alcohol it is? Ethanol? No, it is methanol or ethylene glycol. Methanol is used in wood painting. Ethylene glycol, it is antifreeze that we use in cars, same thing. No, but children sometimes can drink it. So you see, and when oxalic acid, okay, accumulates, it severe metabolic acidosis. What will happen if someone puts you into acid tub full of acid? You will dissolve. So severe metabolic acidosis will dissolve your body. If patient survives, what will happen? Both kidneys will be gone. Ethylene glycol, antifreeze. Okay, methanol, same severe metabolic acidosis. Patient will die. Means CNS depression, respiratory failure depression, it is the same thing. Medullary depression, we know. What will happen if patient survives? Patient will be blind. In USA means you get alcohol freely, so it is not, and it is very cheap. It is not a big problem. But in our countries, alcohol is forbidden. Okay, in India it is forbidden, not that much, but in my country. But in rural areas, people make their own alcohol. Sometimes there is a big party or marriage and there is a big demand. They can't get means usual alcohol, so they try methanol or ethylene glycol to make themselves. Plus, that alcohol we get in China, USA, it is comes from certified factories, and they know how much percent this, how much this percent. But when people make themselves, they are uneducated, no technique. They use methanol, and we call that raw alcohol or thara in our Sindhi. In Sindhi, thara. Have you heard about it? You can ask your parents. Tharu. What is tharu? Okay. So ultimately, what it will do? Oxalic, and in some marriage parties means 80 people die. 70 people die. Means they drink this alcohol, enjoy, they do enjoy, but 80, 70 people die. Have you heard such news in India? In my country, means of course it is not so common, but every once in a year these cases happen. Okay, but these cases can still happen because ethylene glycol is antifreeze. What if a kid opens and drinks it? So first you see now problem is ethylene glycol is first metabolite of this glycoldehyde, and then glycoldehyde is metabolized by aldehyde dehydrogenase into some kind of acid, maybe oxalic formic. Now if there is an overdose of this drug, what you will do? Because you have to prevent formation of all complications arise from what this acid. So now to prevent the formation of this acid, you have to use a drug that will block this enzyme, alcohol dehydrogenase. Okay. So what is the name of that drug? That is fomepizole. So any overdose of alcohol, okay, ethylene glycol or methanol, which drug, what is the antidote? Fomepizole. Okay, when you are using fomepizole, what you are doing? You are blocking the synthesis of acid. Okay, but are you getting rid of this alcohol? It is still body. Then how will you get rid of it? Hemodialysis. What if 70 people drink it, and in our countries means not so many facilities to hemodialyze 70 patients at a time. Okay, so but you will use fomepizole, but that patient may also require hemodialysis because we have to get rid of this from body. So ethanol, but ethanol is a usual alcohol that we drink, and it is metabolized to what? Acetic acid. This is not that much dangerous because acetic acid can be used in our body. Okay. Now how will you remember that oxalic acid causes nephrotoxicity and formic acid causes ocular? You see they are in bold. These are tested. You need to know. Anti-freeze, I don't know how you will remember, but it has to. But what means, what I did, anti-freeze. When it is freezing cold, will you go out to pee? No. So this is how I remember. But easy, you have to choose your own method. I'm very bad in memorization, so I always have to find some way. So you see, alcohol. If you drink alcohol, what it at low doses, what it increases? Sociable. You become more sociable. But what you take too much, then get disturbance, ataxia. Have you seen an alcoholic patient wobbling around? Ataxia. Then ultimately respiratory depression and death. Okay. So that is acute alcohol, and plus patient can have acetaldehyde toxicity. Okay. So sometimes there is a chronic alcohol. Now we want to use a drug so that patient should avoid alcohol. Which drug you will use? Disulfiram. Why? Because if you give someone disulfiram, now he drinks alcohol, disulfiram will block acetaldehyde dehydrogenase. So what will accumulate? And what acetaldehyde body will do? Nausea, vomiting, headache, hypotension. So anytime he drinks alcohol, he feels severe headache, nausea, vomiting. So will he touch alcohol? No. That we use for chronic, means give to someone so that he should avoid it. But there are some drugs I forgot to put here. They must be in pharmacology Kaplan book that have disulfiram-like effect. Metronidazole. Have you heard about metronidazole flagell? It is very common. Flagell. Have you heard about it? Metronidazole flagell. Metronidazole. It is used for diarrhea and these stomach upset. It is very common. What if someone you give someone as means you giving someone flagell to someone, he goes and drinks alcohol. That metronidazole disulfiram like effect. What he will have? Nausea, vomiting, and headache. So any drug that has disulfiram like activity. There are some drugs that I forgot to put here. In that case, will you advise that patient to take alcohol? No, because he will have a bad experience. And alcohol patient, remember alcohol patient has deficiency of two vitamins, folate and thiamine. Why? Because if you are a chronic alcoholic, your body produces acetaldehyde, and what acetaldehyde does? It combines with folate to inactivate it. It combines with thiamine. So, have you heard about Wernsky's Korsakoff in vitamin problems, CNS chapter? Okay, what was that? That was because of thiamine. Okay, I will cover. I don't know because you already covered biochemistry. Now I can't cover it. But thiamine deficiency causes Wernsky's Korsakoff. Okay, chronic alcoholism. What problem it does? Look, alcohol is good, and this is test concept is tested. And as a doctor, you should need to know when there's alcohol, it is metabolized acetic acid. But in the metabolism, what we produce? NADH. Remember from biochemistry, what is NADH? It is full of what? Energy. You covered biochemistry. You know NADH is full of ATP. So, uh, for example, when you drink alcohol, what your body has? Your body has a lot of NADH. So, body's NADH means a lot of ATP. Now, your body is energy rich. But does energy mean nutrition? Nutrition means glucose. Okay. So, normally when you are low in glucose, what your liver produces? Glucose. Glycogenolysis. After glycogen is depleted, your body produces glucose. But that liver will produce glucose only when body is low in ATP, because the liver is made in such a way that it sees when body is low in energy, means we need glucose. So liver produces glucose. So if you are drinking alcohol, your body is full of ATP because there is a lot of NADH. Will your liver produce glucose? So you will have what? Chronic. And what energy brain can use? Can brain use fatty acids? Brain can only use glucose. So these patients have chronic hypoglycemia. When you have body is full of energy, means ATP, whatever you eat, what body does to that? Stores that as a what? Fat. You see, when we eat food, whatever our body can use, what rest body stores as what? Fat. So now you are drinking alcohol, means body is full of ATP. What patient means that body will do to that food you are eating? Liver cannot metabolize it. So liver thinks I'm already full of ATP. Let's store it. And what it does makes what? Fat. So liver itself becomes fat. Your body also become hyperlipidemic. Okay, so fatty liver we already know is very bad. And is fat good? No. So your body becomes a factory to produce fat. And hypoglycemia. Chronic hypoglycemia good? So this is very bad. And what about whatever long-term alcoholic? If the patient is alcoholic, now whatever little money he gets, he spends on alcohol. Does he take enough food protein? So what will happen to muscle wasting? So chronic alcoholism use, is it good? Alcohol is very bad. And then gout. Gout means alcohol is metabolized into lactate. That lactate competes with what? So alcohol is contraindicated in gout. Remember, rheumatology covered that any patient who has gout, we should avoid alcohol. Now you understand this concept. In biochemistry, they give you case someone who's a marathon. No, marathon need to run for 3-4 hours. When they run, are they eating when they are running? So they need glucose. Where does that glucose come from? Glycogen in liver. But after 2 or 3 hours, that glycogen is gone. Now, where does that liver come from? Gluconeogenesis. By gluconeogenesis, liver is making what? Glucose. Now, that patient, was sweating during marathon running, and he thinks when he reaches finish line, he suddenly drinks beer. Okay. As he drinks beer, okay, after 2-3 minutes, he collapses and is dead. What was the problem here? That they can test this in biochemistry, but you should also know. He was hypoglycemic, so his liver was making what? Glucose by gluconeogenesis. Now he used beer. Beer has alcohol. As soon as alcohol enters the body, alcohol is as ATP. So what his liver thinks? Now I am energy full. I need to shut down gluconeogenesis. When liver shuts down gluconeogenesis, what happens to glucose? Glucose goes down, hypoglycemia, severe. Brain does not get enough glucose, and that patient is. So after running too much, 2-3 hours, or after any kind of exertion, is it wise to use beer or some juice? It is better use juice, because juice will give you water, juice will give you energy, glucose, so that brain can use it. Now you understand the concept of why chronic alcoholism patient have hypoglycemia, why chronic alcohol patient has fatty liver. So alcohol is energy rich, but it nutrition, zero nutrition, I would say. It is energy rich but no nutrition. Nutrition means glucose. That glucose should come because brain can only use that. So don't think that alcohol gives a lot of ATP, so it is good. ATP doesn't mean nutrition. Nutrition means glucose. Okay. So this is very important concept. Do you drink too much? Use it too. I tried, but I means used for a short time. Then I didn't, because it gives me GERD, and GERD is very bad. Otherwise, I enjoyed it, but GERD is. Should we finish this or wait for 5 minutes? What do you want? Finish it? Okay. I think you are energy rich. You will drink alcohol. Okay. So, epilepsy, anticonvulsant or epilepsy. Pharmacology is very interesting, very easy. But you must study with the question, because without question, I again repeat it, you can't learn anything. So seizures, you see, seizure means, epileptic attacks. They result from episodic electrical discharge in cerebral neurons, because some neurons in your brain go crazy. and they have prolonged depolarization. They keep shooting, so you have seizures. So during which sustained high frequency repetitive firing occurs, followed by prolonged hyper. You see, some patients have seizure attacks for 2 3 minutes after they sleep. Why they are sleeping? Because they go crazy. First they fire, fire, fire. After they have prolonged hyper, first they are depolarized, but after that are hyperpolarized. So what is the goal? Goal of is to maintain normal or restore normal patterns of electrical activity. Okay, so electrically these neurons become crazy. So mechanism of action is you have to decrease conduction. All conduction neurons occurs through which channels? Action potential sodium channels. So you will block sodium influx through fast sodium channels, and that is the mechanism of carbamazepine and phenytoin. Or you increase inhibitory tone. What was that? Inhibitory tone, GABA mediated hyperpolarization, because GABA also causes hyperpolarization that we just covered, barbiturate and benzodiazepine. Or decrease excitatory effect of glutamic acid. Glutamic acid is an excitatory neurotransmitter. We have to decrease that. That is through lamotrigine and topiramate and felbamate. So these subtype of receptor AMPA, NMDA, no need to remember. Are in thalamic neurons block presynaptic calcium channel. For any neurotransmitter to be released, calcium first enters means a presynaptic neuron, and then neurotransmitter released. If you prevent calcium influx, can neurotransmitter be released? No. So all are these mechanisms. I literally in pharmacology you need to know three things: mechanism, use, and side effect. Just we covered in alcohol. What was side effects? Hypoglycemia. Okay, if you go back, you must note this: hypoglycemia, fatty liver, gout, folate, and thiamine deficiency. They can test you anything. As a general doctor, this is ABC, not too much. We don't teach you in details. So I means you should know these things. So what mechanism, use, and side effect. But common side effect, rare side effect if it is life threatening, then common side effect every doctor of drugs, every doctor should know. So you have seizure types. Have you covered these seizure types? What is partial, simple or complex? What is partial? Partial means my only one hand, this has undergone seizure, or one leg, or one side of face. Okay. What is then? That can be simple or that can be complex. What is complex? Complex means any patient who loses consciousness. In partial, okay, if one part of brain is firing, it means maybe part of brain that is controlling hand, okay, that is firing. What about general tonic-clonic? Have you seen someone like this? Seizures, then stop, then again seizures. Okay. First he tone increases, and that patient, often falls down on the floor, and then he is seizing like that. Okay, if you go to YouTube, you must watch all these videos, because okay, partial means one part of brain is firing, so one part of body. General means all whole brain is firing. If whole brain is firing, your whole body is seizing. Okay, your body seizes, then loses tone, means it is clonic. Relaxes, then again seizes. Okay, so then what is general absence? What is general absence? And this is very interesting. I am sitting here. Okay, this often is noticed by parents or teacher in small children. So suddenly I'm staring blank. I'm out of this world. Means I'm absent from this world. I'm oblivious to everything. And these happen only for 2 or 3 seconds. But what? In a minute you get 3 5 attacks. Your parent is saying something to you. Will you listen completely? If you get 2 or 3 attacks of this in a 1 minute, our teacher is giving a lecture. Can that children pay attention? No. Means he's sitting like this, but he becomes absent from this world, just staring blank like this, oblivious to everything. When he comes back, he doesn't remember anything. Okay, that is general absence. You can also go to YouTube and see the videos. It's very interesting. And status epileptics, I already told you that means patient keeps seizing for more than 30 minutes. If he is seizing means respiratory muscles are also seizing, means he cannot breathe, and hypoxia, these problems. And seizing patient, are they conscious or unconscious? If his whole body is seizing, unconscious. So can they maintain their gag reflex? What if they vomit? Where they it will go? Respiratory system, aspiration. I already covered respiration. Aspiration is worst nightmare. Not only brain but aspiration. They can bite their tongue and these things. Okay. So what is now? These drugs are very easy to remember. So what is drug of choice for partial and general? Okay, status epileptics, we already know we have to use a drug IV that has to be benzodiazepine. What is that? Lorazepam, we already covered, our diazepam, but especially lorazepam. And for general absence, drug of choice is what? Ethosuximide. Second line is valproic acid. For all other, what is drug of choice? Valproic acid, phenytoin, and carbamazepine. Is it easy to remember? Okay. You can see VPC, valproic acid, phenytoin, and carbamazepine. But for general absence, you have to pick ethosuximide. Okay. Status epilepticus, pick lorazepam and diazepam. More about epilepsy management that you will study in internal medicine. So now you know the subtypes and you know the drugs, you know their mechanism. All drugs mechanisms are here. Okay, subtypes of epilepsy are here. Drug of choice, valproic acid, and these things are here. So what are we left with? Side effect. Now we have to study that. Phenytoin, we already know its mechanism. We already know it is used for seizure. We already know it follows which are order kinetic. There were three drugs that were following zero order kinetic. What were those? Remember from last lecture, high doses of phenytoin, ethanol, and aspirin, okay, remember that. So zero order, there were three drugs that you need to remember. So it also induces P450 system. What are anti-epilepsy drugs that induce P450 system? One is phenytoin, other is barbiturate. We covered just now. These are general inducers of P450 system. Okay. Side effect, you know, they can cause CNS depression. All anticonvulsant, because they act on CNS, they can cause CNS depression. Uh, there are only two or three drugs that cause gingival hyperplasia. One is phenytoin, you have to remember. How do you remember other things? Osteomalacia, vitamin D, and megaloblastic folate, aplastic anemia. So you have to check. And most of these drugs cause these problems. This causes hirsutism. I will later on tell you how to remember hirsutism. And these are also teratogenic. But which class they were? X or D? D. Because if we don't give anti-epileptic drugs and mother has seizures, baby will be lost. If we give this drug, baby may live, but with what? Cleft lip and palate. So you want a baby dead or baby with cleft lip and palate? Cleft lip and palate. So they are which class? Although this is teratogenic, but benefits outweigh risk. So you will use this drug. Carbamazepine mechanism we already know. It is also used to severe state epilepsy, but for one it is drug of choice. What is that? Trigeminal neuralgia. Have you heard about trigeminal neuralgia? Shooting pain in facial. You just talk, you choose something, something touches here when you're shaving, it causes severe shooting pain. But just for seconds. For example, anything touches here, even air touches here. When you are shaving or when you are chewing something, anything touches. Okay, you have shooting means pain, but that pain is just for few seconds, but it's still pain, and shooting it is very bad, so it is drug of choice. And another, it is used for bipolar disorder. Bipolar disorder, how to remember? Have you covered behavioral science? So it is one of drug for bipolar disorder, carbamazepine. Okay, and another epilepsy drug that is for bipolar, it is mania. Have you heard about mania and depression? Bipolar, sometimes they are manic, sometimes they are depressive, sometimes very high, sometimes very low. But more about this I can only cover in behavioral science. Here I just have to tell you that it is used for bipolar disorder. It also induces P450 system. Now all anticonvulsant drug can cause venous depression. Then what were side effects of previous drugs? Osteomalacia, megaloblastic anemia, aplastic anemia. These are same. Okay. So exfoliative dermatitis, I never heard about it. So same teratogenicity, cleft lip, palate, spina bifida. Okay. So osteomalacia, megaloblastic anemia, and aplastic anemia. You see both in phenytoin. You see in also carbamazepine. This is how you will remember it. Now what are you left with? Valproic acid. What's the mechanism of action? Similar to what was drug of choice in most epileptic types. Why? Because it has mechanisms similar to phenytoin. It also inhibits GABA. It also blocks calcium channel. Drugs either block sodium channel or GABA or calcium, but it blocks everything. So it has multiple mechanisms. So it is best drug. Okay. It is used for seizure. It is also used for bipolar, but mania or depression. Mania. Carbamazepine can be used for mania, depression, but this is used for only mania. But this is also used for migraine prophylaxis. Look, phenytoin was only used for seizure. Now how you remember that? Because you have to memorize it. Because you have not gone to clinic, so you have not prescribed drugs, so you don't remember it. Phenytoin can only be used for seizure. Carbamazepine can be used for seizure. It can be used for bipolar disorder, but it has one extra use, that is drug of choice. What is that? Trigeminal neuralgia. Same way, valproic acid can be used for seizure, mania, but it can also be used for something else. What is that? That is migraine prophylaxis. Okay. So now, how you remember this? Look, phenytoin and carbamazepine induce P450 system. Then what does valproic acid does? It inhibits. Okay. And if phenytoin causes hirsutism, hair overgrowth, then what does valproic causes? Alopecia. You know alopecia means hair loss. Okay. Now you see how it is different from phenytoin. Phenytoin induces P450 system. This inhibits. Phenytoin causes hirsutism. It causes alopecia. Now, what are similarities between phenytoin and carbamazepine? You see, if you go back, phenytoin causes old osteomalacia, megaloblastic, aplastic anemia, and carbamazepine also causes that. And this also causes increased ADH secretion, so it can cause syndrome of inappropriate SIDH. Remember, SIDH from endocrine system. Now, this causes pancreatitis and plus hepatotoxicity. So all drugs that cause liver toxicity, they are very high yield. So valproic acid is bad for liver. It is for pancreatitis. Okay, it is bad. So you have to remember these things, especially drugs that cause hepatotoxicity. Okay, one drug we are covering, that is valproic. Later on I will, when I reach teach you each drug, then I will tell you this also causes liver problem, this also causes. Now it causes all, almost all seizure drugs are teratogenic, spina bifida. Okay, now how will you remember? You see, USMLE doesn't test these things, but to be on the safe side, let's make it easy. What does means phenytoin cause? Cleft lip and palate. Then what was last drug? Valproic acid. What does that cause? And what is the middle drug does? Both. Okay. If you have to memorize, you have to make it easy for yourself. Okay. Then ethosuximide. We know its mechanism already. It is blocks calcium channels. What is used for? Used for absence seizures. So, and let's study now journal features. Ethosuximide already covered that it is the best drug for what? Drug of choice. Best drug. Anticonvulsants are depressants. They are additive with other seen as depressant. If someone is, those patient was epilepsy, they take these drugs for many years. So will you stop these drugs suddenly? Will you stop these drugs suddenly? No. Avoid whenever someone has been using drug for year or 6 months. Never stop a drug abruptly because this will precipitate what? Seizures. And these are mostly induced P450 system. So what will happen to efficacy of all contraceptives? It will go down. Instead, they can use condoms or some other method. Okay, because all contraceptives, and this is highly tested. And when someone is pregnant, which drug is safest? Phenobarbital. Because remember, previous 3-4 drugs were teratogenic. So during pregnancy, safest drug is phenobarbital. Now other anticonvulsant drugs, felbamate and lamotrigine. Mechanism we already know, they block glutamate receptors. They are primary drugs or adjunct drugs. Look here, they are adjunct. They are not primary. What are primary drugs? Primary drugs were valproic acid, phenytoin, and carbamazepine. So if some patients seizures are not controlled with valproic acid, carbamazepine, then we will add. So these are adjunct or add-on. What are second drug that you will add? There may be felbamate and lamotrigine. Then when we come to side effect, felbamate I have not seen any question, but lamotrigine it is highly tested. Stevens Johnson syndrome. Stevens Johnson syndrome I covered in dermatology, skin pathology. Okay, and if you go there, did I cover it? Skin pathology I covered it, must be there. Steven Johnson syndrome. Okay, you can go and look at that. This is classic. There are very few drugs that cause Steven Johnson. Out of that, one is lamotrigine, and lamotrigine is highly tested. Okay, so gabapentin. It is also used in seizure, but it is used for one other. What is that? Neuropathic pain. What is neuropathic pain? What is neuropathic pain? Pain caused by nerves. Have you seen herpes? Sometimes herpes patient has severe pain. Okay, we are young means it will just cause little burning, but some old patient who has immune system is down, they have herpes but very severe pain. That pain is caused by which? Nerves. And one complication you have it in diabetes. What was it? Peripheral neuropathy. Have you heard about it? What are signs and symptoms of peripheral neuropathy? What if you have peripheral neuropathy in leg or hand, and your hand or leg means you feel pins are tingling all the time? Will it be comfortable? If someone means pricks you with pins all the time, or tingling, or burning, or your hand is burning all the time. Okay, it is not comfortable. You can't sleep, you can't work. So that pain, that is what type of pain? Neuropathic. So for neuropathic pain, we can use two drugs. One is gabapentin. Okay, other I will cover later on. Right now, you just remember gabapentin. Other is amitriptyline, triptyline class of drugs. Okay, but tricyclic antidepressant. That is antidepressant chapter. Tricyclic antidepressant. That is so. Now let's talk about it again. For neuropathic pain, which two drugs you can use? Gabapentin and antitricyclic antidepressant amitriptyline. For trigeminal neuralgia, what is the drug of choice? Carbamazepine. Okay. And for absence here, what is drug of choice? Succinide. For lamotrigine, what side effect is classic? Steven Johnson. Now, if you go read first aid is all these things. But first aid is for those students who already know basic. So we are just covering basic. Once you read this, then go back and read first aid. So they will be all important things. Okay. So now you know what is neuropathic pain also. So I think we can have a 5 minute break. Where you just listen, but I talk. 5 minute, actually 10 minute break. Pharmacology is easy or difficult? But everything is easy. But if you study, give time and solve question. You have to study and you have to solve question. So next is drugs used in anesthesia. So remember from first chapter, drugs that were highly fat soluble, which rules they follow? Redistribution. Remember first, because they are highly soluble, they first will go to CNS, from that they will redistribute. But here it is so simple, they don't tell you even that much. So those drugs you will give by which route? IV or lungs? Anesthetic drug you give by lungs. But sometimes some very short acting for induction, we can use IV drug. We just covered in first chapter today two drugs. What were those? Thiopental and midazolam. Remember, they were very short acting CNS depressant sedator, so we use them to induct. Okay. So induction, because we rapidly want to put patient on an anesthetic state, so we can use IV drug. But for maintenance, we have to use something else. Okay, so that should be long acting, that can be used as a gas. So now we have two prototype drugs. One is halothane, other is nitric oxide. So here you have two values, that is very important. Okay, as a general doctor, will you be dealing anesthesiology all the time? So they just want to test you two or few things that are very easy. MAC value and blood gas ratio. Now what is MAC value? What is blood gas ratio? Let's go and study this. Anesthesia protocols always need several agents in combination. Inhaled anesthetics have varying potency in proportion to their lipid solubility. So over here potency is known as what? MAC. For other drug we use term potency, but here we use MAC. Minimal alveolar anesthetic concentration is defined as concentration of inhaled anesthetic as percentage of inspired air at which 50% of patients do not respond to surgical stimulus. What is surgical stimulus? Cutting. Okay, that is surgical. So MAC is a measure of potency. And most anesthetic drug you give IV or as a part of inspired air. As a part of inspired air. So here instead of dose, what we will use? Percentage of inspired air. So it is a measure of potency, and so at which 50% of our patients do not respond to a surgical stimulus. More lipid soluble anesthetic, lower the MAC, and greater the, because if it is more lipid soluble, it will means very fast cross membrane and go into blood. From blood it will go into brain. So more lipid soluble, greater potency. If more potent, its dose should be low or high. Remember from chapter 2, more potent drug get the same effect at a lower dose. Okay, so it means now lower the MAC, means percentage has to be lower. So and MAC values are additive, and of course MAC values will be lower in elderly in the presence of opiate or sedator, because CNS depressants are always additive. Now rapid onset and recovery depend on blood gas ratio. So that was potency. MAC was potency. What is blood gas ratio? More soluble the anesthetic in blood, slower the anesthesia. What does mean? Blood is water or blood is fat, lipid? Blood is water or blood is fat? Water. So anything that is more soluble in water, it is water soluble or lipid soluble? Water soluble. Anything that is water soluble, can it cross membranes freely? So it will be slower in onset or faster? Slower. Now understand this concept. So anesthetics with a high blood gas ratio are associated with slow onset. High blood gas ratio means more of it will be in blood, less of it will be in gas form. Okay. Anesthetics with a high blood gas also associated with slow recovery. What about anesthetics with low blood gas ratios? Low blood gas ratio means that is not soluble in blood. Mostly it is in gas form. Blood form soluble in blood is low, but a high more part of it is in gas form. So this ratio is low. So it will have fast onset and recovery. Now you understand this blood gas ratio. Okay, you also understand MAC is potency, blood gas ratio. What does indicates? Slower onset or fast onset. Now over here, which drug has a high MAC value? Nitric oxide. You see, it is 104%, but it is just 0.1%. So which is more potent? Nitric oxide or halothene? Halothene is very, very potent, because when you give nitric oxide, 104% of inspired air has to be what? Nitric oxide. What will be the oxygen part? It will go down or decreased. So, and now you see, one value was MAC value. What was the blood gas ratio? Which has a high blood gas ratio? It is halothene. So, which will be faster in onset? Yeah, because blood gas ratio is very low. So, it is more blood soluble, more water soluble. Now, they can test things like that. Cardiovascular effect, it is very easy. Halothane, you know, halothane sensitizes heart to catecholamines. Catecholamines means adrenaline. So adrenaline means it can cause cardiac arrhythmia, it can cause malignant hyperthermia, and it causes hepatitis. So here now we are covering another drug that causes hepatitis. What was first drug that we covered? Verapamil. Last, just last chapter, Verapamil. Okay. So now you see it has low blood gas ratio, so it has a rapid onset and recovery. But what it can cause? Because when you give inspired air, 104% is nitric oxide. So what part will be oxygen? Very low. So it will cause diffusional hypoxia. And when it causes diffusional hypoxia, it also can cause spontaneous abortion. Okay. Hypoxia means, I don't know what is mechanism for spontaneous abortion, but you have to memorize it. So these are classic drugs that they teach you anesthetic. For means nitric oxide has a high MAC value but low blood gas. It has a low MAC value but high blood gas ratio. And they want you to know what MAC value indicates. MAC value is same as the potency. What is blood gas ratio? Blood gas ratio means how much is soluble in blood, how much is in gas form. More soluble in blood means it is water soluble. It cannot cross blood-brain barrier, lipid membrane, so it will be slower in onset. So classic side effect of halothene: hepatitis, malignant hyperthermia, and cardiac arrhythmias, especially malignant hyperthermia. There are very few drugs that cause malignant hyperthermia. One is halothene. What drug was causing gingival hyperplasia that we covered last chapter? There are two drugs that cause maybe three drugs. One is phenytoin, other is cyclosporin, one I don't remember. Cyclosporin we cover later on. One other drug also causes gingival hyperplasia, but I don't remember. Just like that, there are a few drugs that cause malignant hyperthermia. And I think two of them are in this chapter. One is halothene, other is acetylcholine. So I already covered this, so you know this. Now let's study drugs. So thiopental we already know. We covered that in barbiturate section. Midazolam we already know. It is short acting, okay, and is used for induction, and it is used for outpatient surgery. What is outpatient surgery? Someone has just some trauma, we need to do stitching. for outpatient. Propofol is used for an induction and maintenance of anesthesia. Otherwise, it is seen as a cardiac depressant. All anesthetic will be seen as depressant. But what is about cardiac depressant? Can you use it in congestive heart failure? Yes, heart is already weak. So, okay, propofol is like that. And what about halothine? Can you use it in someone who has angina? Yeah, it can cause arrhythmia. So these things you need to note, not to read, but we should also fentanyl. It is an opiate. Opiate we will cover later on. Opiates can cause respiratory depression. So opiate it is a next chapter. They cause respiratory depression. So what are we left with? We are left with only ketamine. Ketamine, remember, it is also used for an abuse drug in parties. You must have heard about it. We are in USA. They are highly used. So it causes dissociative anesthesia. What is dissociative anesthesia? Where if you want to do outpatient surgery in a children, will children allow you? Okay. And on the other hand, you cannot do general anesthesia. General anesthesia means you have to make patient sleep. So in that case, you have to use a dissociative anesthesia. What is now dissociative? Patient psychologically, mentally dissociated. Okay, you will be doing surgery, but will not know anything. So when you take this drug, this is also abuse drug like cocaine. Why? Because this causes very beautiful hallucinations. Okay, I don't know what kind of beautiful hallucination it can cause, but you are hallucinating. You are in heaven. But what if somebody cuts your hand? Will you feel it? No, because you are dissociated from body. Okay, so you are dissociated from body, and it is used mostly in children. And what side effect it can have? Hallucination and can you use it in heart problems? No. Can you use it in a brain injury? There it increases intracranial pressure. So you see, mostly they are anesthetic, but small things when they tell you means propofol is both CNS and cardiac depressant. Over here, ketamine is both CVS cardiovascular and CNS stimulant. Got this? These small things they can test you. Fentanyl because it is an opiate, so it causes respiratory depression. Okay, so these small things they can test you. Maybe you just read it, don't note these things. Okay, but otherwise this is not the job of general doctor, so they rarely ask these things. But ketamine you need to know because it is also an abuse drug. So emergent these patients will have, otherwise they give you that we gave patient anesthesia, we did surgery. After surgery now patient is having hallucinations. Which drug they use for anesthesia? Ketamine. Okay, so just like that, any patient has a angina, arrhythmia, you cannot use ketamine. Brain injury, you cannot use ketamine. Okay, in children you can use this thing. Okay, now you understand this all anesthetic very easy. So local anesthetic. So now you want to do surgery in hand, but to do stitching in hand, can you do general surgery? Sometimes you need to do for example, you are taking tooth out. To take tooth out, can you do general anesthesia? For general anesthesia, need to be in means special setup. So for to do some surgery in tooth, to do some work on tooth, or to do some stitching in hand, you need what? Local anesthetic. But even children, when you do local anesthetic, they will cry a lot. So in children, what choice you have? Ketamine. Okay. So now you see children. Do children have CNS problems, stroke, thing like that, or heart problems? No. Okay. So uh, this channel we will cover in cardiac section. Still we are not there. So mostly local anesthetic they block which channel? Sodium channel. All conduction action potential occurs when sodium goes inside. So if you block sodium channels are blocked, can there be any conduction of pain? No, nerves will block, nerves will not work. So no pain, nothing will go to CNS. One thing, how they work. Remember ionized, non-ionized, to enter inside a cell, because you see it works from inside cell. It is not working from outside. This is local anesthetic. These are toxins. Tetrodotoxin, puffer fish are red tide. Okay, they are exotic fish toxin. They block sodium channel, but these work from outside. What about a local anesthetic? They work from outside or from inside? They work from inside cell. So for them to work, first they must enter cell. To enter cell, they must cross cell membrane. So they must be charged or uncharged. Uncharged. So this is uncharged. Once in interface cell, it becomes what? Charged. Now can it leave cell? No, it becomes trapped. And this charged form is the active form. What about uncharged form? Inactive. You see, beautiful use of biochemistry. How they made it. They made it uncharged, inactive, so that it can cross membrane. Once it enters membrane, okay, it becomes charged and active, and from inside cell it will block sodium channel. Now you know their action. What is their mechanism? What are drugs? Okay, all drugs that end with can. And remember from first chapter, one was ester, other was amide. What was easy way to memorize that? Drugs that have one eye, they are what? Ester. Drugs that has two eyes, they are amide. Okay. Now if someone is allergic to lidocaine, can you use bupivacaine? No, means he is allergic to amides, so you cannot use another amide. Which drug you can use? Procaine. If someone is allergic to cocaine, can you use benzocaine? That is tested. Okay, and esterases are in plasma and blood, but amide is metabolized in liver. That is small thing will not be tested, but this thing is tested. If someone is allergic to lidocaine, you cannot use cocaine, ester, amide, that one. The mechanism I already explained. Nerve fiber sensitive. Which nerves are most sensitive? Which nerves are more active? Smaller nerves or bigger nerves? Remember myasthenia gravis we covered in pathology? Which muscles were more sensitive to blockade of antibodies? Smaller, because smaller nerves or small muscles are always active. You see, eye muscles are always active because I need to maintain vision. If eye muscles are not active, I will have ptosis, diplopia. So in myasthenia gravis, eye muscles were affected first. So here also, smaller diameter and who have a more high firing rate, they are more sensitive to blockade. But the recovery is in reverse order. So these B and C type of nerves are most sensitive, means they are blocked first, but they recover last. Okay, that we already know. And when you are using a local anesthetic, do you want that anesthetic to spread to the body? No, why? Because if it spreads to body, what if blocks sodium channel in the heart or brain? Your heart will stop. So we want them to be localized, do not spread. When a drug spreads, through which route it will spread? Blood vessel. All drugs spread to the body through blood vessels. When you inject a drug, what if you use a drug that causes vasoconstriction and keeps a local anesthetic at that place? What is that drug? Epinephrine. So I covered that, but I will again repeat it today. Okay, because you see, what are their side effects if they spread to the body? Neurotoxicity and cardiovascular toxicity. Do you want that to happen? So mostly they are used with some drug that has alpha 1 agonist. What alpha 1 agonist will do? It will decrease local anesthetic absorption to systemic circulation, and it will not spread to brain and heart. And plus, when it is localized, it will have prolonged effect and less toxicity. For cocaine, do you need a drug that is alpha 1 agonist? Remember alpha 1 agonist, what it does? It vasoconstrict. Because cocaine intrinsically causes vasoconstriction. So will you use cocaine, means alpha 1 agonist with cocaine? No. Cocaine is local anesthetic, but it also have alpha 1 agonist activity. Okay. Sometimes they give you someone has a trauma, it is macerated. Skin is macerated. Macerated, will it be painful? Will it be bleeding? But when skin is macerated, can you do stitching and repair it? So now you have to take care of pain. You have to take care of bleeding. Which drug you will use? Cocaine. Because cocaine is a local anesthetic, it will also cause vasoconstriction. That will decrease what? Bleeding. Now you understand it? Okay. So doctor you can see this in use in clinic. So local anesthetic, but it also causes vasoconstriction. So with most other drugs, you will use a vasoconstrictor, but not with cocaine. And allergies. If someone is allergic to ester, you will use what drug? Amide. Okay. Any patient who's anesthetized, means is sleeping. But does it mean that any patient who's sleeping will not move around? When you are sleeping, you are still or you are moving around? Moving around. So we also should use skeletal muscle relaxant. So that patient should be. What if you are doing surgery in brain and patient suddenly moves? You will cut through brain and he will be dead. So we want patient to be what? Immobile. They must have skeletal muscle relaxant. Have you heard about criminals killed by poisoning? What we do? First we give them anesthesia. They sleep. Okay. Then we give them skeletal muscle relaxant. Okay. So that they should not move. They are sleeping, but they still can be painful. So then we give them poison. That poison you will see in physiology, potassium chloride. You know, potassium can cause arrhythmia and kill. So now patient will be dead, but he will not feel anything. It is as if he is dying in sleep. Okay, the same way. So for skeletal neuromuscular junction, which receptors we have? Nicotinic, because they open which channel? Oh, sorry, acetylcholine. Acetylcholine channel, when acetylcholine binds to neuromuscular junction. Remember last week? So it will open sodium potassium channels. Now nicotinic receptors have 5 subunits and 2 acetylcholine bind to each alpha subunit. It has 2 alpha. So to open sodium channel. When sodium channel opens, this causes what? Depolarization. So depolarization means it is used in ICU anesthetic protocols in ICU to afford muscle relaxation and immobility. Anesthesia we know. What about ICU? Some patient is severely traumatized. We want to do some exam or stitching. He is not allowing because of pain. He is just moving around. To make him immobile, what we can use? Skeletal muscle relaxant. Okay. Now these drugs, how should they act? They should block this. If they block this receptor, can muscle depolarize? If we block this receptor, can muscle depolarize? No. If muscle cannot depolarize, will it contract? No. So patient will be immobile. What we call them? Non-depolarizing. But non-depolarizing are competitive. What do you mean by competitive? Last time I covered. Because non-depolarizing, where they bind? They bind here. Okay, at the block channel. If we increase acetylcholine will push it away and it can be reversed. Remember from last week's chapter. So those classic drugs are all drugs that end with the curarine. Remember, in olden days, people used to do hunting in jungle, and they use arrow. that arrow has a poison. What type of poison that is? That is curarine. Why? Because when that arrow hits animal will be immobilized. Okay, because you don't want to use a poison so that when you use that animal's meat, you die yourself. Okay, so this is competitive, so this is also reversible. It has no effect on cardiac and smooth muscle, no CNS effect. Why? Because acetylcholine receptors are only skeletal muscle. So drugs normally they don't test individual drug. You just need to know them as a group. But they can ask a tracheurum because it is metabolized to what? Ladenosine. So ladenosine can cause seizures. It is metabolized to ladenosine that can cause seizures, and plus it is safe in hepatic and renal problems. So this is why something is special about it. Safe in hepatic renal impairment, plus it is inactivated to ladenosine that can cause seizures. So if we have a non-depolarizing competitor, we must also have other type. What is other type? It must be non-depolarizing or depolarizing. It must be competitive or non-competitive. Non-competitive. That is what is it? Is succinylcholine. Why we call it depolarizing? Because what is half-life of neurotransmitters? Seconds. For acetylcholine, it comes, opens this channel, and it is destroyed. But if you use a synthetic acetylcholine, that is succinylcholine, okay, succinylcholine, it will come, okay, open the channel, but will it be depolarized? So ultimately, initially it will be depolarized, ultimately it will become what? Insensitive. What if I teach you for 24 hours continuously? Initially, you understand, but after a few hours, 6, 7 hours, you will become insensitive. You will not respond, you will not understand anything. Same thing happens here. Depolarizing means it has two phases. First phase is because it opens channel, so it causes depolarization, fasciculation, okay. But phase two, what is it? It is desensitization. Now receptor will not be receptive. It will not respond. Is it irreversible? No. What side effect it can cause? Malignant hyperthermia. So which two drugs cause malignant hyperthermia that are in this chapter? Halothine. Which two drugs cause liver problems that we covered up till now? Valproic acid and halothine. So it will take you some time to memorize, but they are very important. I know at tips because I had done a step 1, 2, 3. So these are the same things they ask again and again, and you have to practice a lot of questions to remember these things. Okay. So why this depolarizing acetylcholine causes malignant hyperthermia? Remember, sometimes when it is very cold, you shiver. Why you shiver? To produce heat. So this drug causes what? Depolarizing fasciculation. So means sometimes not all patients are equal. Sometimes patients too much contraction of muscles, and muscles produce what? Heat. Your body temperature go very high. Malignant hyperthermia. Why hyperkalemia? When some muscles contract very soon, they can break down. Okay, rhabdomyolysis. And when muscles break down inside cell, which electrolyte is very high? Potassium. So it can cause rhabdomyolysis means breakdown of muscle. Which one side effect is what? Hyperkalemia. What do you mean by atypical pseudocholinesterase? It has a very short duration, but in some people, okay, they don't have typical pseudocholinesterase. They have atypical. It is very slow acting. If it is very slow acting, will its duration of action be long or short? Long. So those patients can especially have hyperkalemia and malignant hyperthermia. And they give you classic history. Means someone comes and he says that someone in my family died during anesthesia. What are they talking about? It can be either halothine or succinylcholine. They died because of what? Malignant hyperthermia. Some people during anesthesia do die. Okay, that may be malignant hyperthermia. We try to recover it, but some patients do die. Centrally acting skeletal muscle relaxant. Remember, some people have stroke. Stroke means, we have two motor neurons, upper motor neuron and lower motor neuron. So lower motor neurons are always active. So they have to be controlled by upper motor neuron. If in stroke upper motor neurons are gone, what happens to lower motor neurons? They are overactive. So patient has spasticity and muscles become so spastic, so contracted they cause pain. In that case, we have to relax them. In that case, you use benzodiazepine or some other drug, because benzodiazepine will also cause sedation. So you will use some other drug. Okay, benzodiazepine you cannot use chronically. For short term is muscle relaxant in epilepsy you can use, but for stroke you can use some drug that will act through GABA B receptor. And there's only one drug that acts on GABA B for your purpose. What is that? Baclofen. First used spasticity. So malignant hyperthermia we already covered. Muscle become rigidity. There is hyperthermia, hypertension, acidosis, and hyperkalemia. Because when muscles contract too forcefully, some muscles die and they release potassium. So what will you use? Which drug you will use? When muscle contract, they for their contraction what they need? Calcium. What if you block the release of calcium? What you block the release of calcium? Then will muscle contract? No. So one uses drug is gentle. What other things you can use? Other supporter. What do you mean by supporter? If there's a patient is too hot, hyperthermia, you will use cooling blanket. Okay, if patient is seizing, you can use diazepam, because you have to use a muscle relaxant. That is what supporter. Plus you can use dentrolin. So they can give you any type of drug. And two drugs that cause malignant hyperthermia we studied here. What were those two drugs? Succinylcholine and what is other drugs? Antipsychotic. Okay, but over antipsychotic we don't call it malignant hyperthermia, we call it neuroleptic malignant syndrome. Same thing, same disease, but we give it a different name. Okay, you see it is associated with inhaled anesthetic. What is inhaled anesthetic? Halothine. Or skeletal muscle relaxant. What is that? Succinylcholine. Or it is antipsychotic drug, but over there we call it neuroleptic malignant syndrome. Neuroleptic malignant syndrome is same thing as malignant hyperthermia, but it is caused by antipsychotic, so we give it a different name. So dentrolin, please remember it. What's the mechanism? It blocks release of calcium. So this chapter is also very small. After that I will cover adrenergic and cholinergic. We still have 2 hours to go. So do you have opiate? Does our body has opiate? After exercise you feel so good. Why? Because after exercise we have endogenous opiate peptides that are released. These are endorphins, enkephalins, and dynorphins. Why after exercise we feel so good? Because we have endogenous opiates. When sometimes you are very excited in a sympathetic mode, you fight with somebody and they are hitting you. Do you feel the pain? But when you go home, then you feel a lot of pain. I'm hurting here, I'm hurting him, he beat me so much. Why now when you are fighting you don't feel the pain? Some patients even they have big accident where they don't feel the pain until they come to the hospital. Why? Because in extreme sympathetic mode you have endogenous opiates released. In exercise also endogenous opiates. They not only, and when you have a severe pain trauma, which drug you use? You use opiates. Got this concept? So three receptors are mu, kappa, and but what is the main receptor? Mu. Most important pharmacology is mu. So if they inhibit pain, they should be inhibitory or excitatory. Inhibitory. They should be inhibitory, not excitatory, because they inhibit pain. So mu pharmacology is the most important. Now you have to understand one more thing. Do they decrease pain? No. NSAIDs, analgesic. When we say the analgesic, they decrease pain. But these drugs do not decrease pain. Pain is there. They just increase the pain tolerance and decrease perception and reaction to pain. Pain is there. You don't feel it. You are more tolerant, okay, and you are less sensitive, perceptive to pain. So please look at these words, just like benzodiazepine and barbiturate. Benzodiazepine potentiate GABA action and barbiturate prolong it. So NSAIDs decrease pain, but these drugs don't decrease pain. They increase pain tolerance and they decrease pain perception. You have to remember it. And they cause respiratory depression. So whenever someone has because takes an overdose opiate, heroin is also opiate. Okay, morphine is also an opiate. Fentanyl also opiate. Fentanyl patches. Some patients don't get heroin, so they get fentanyl from clinics. Okay, so respiratory depression. When someone's respiratory system is low, what you give them? Oxygen. But what will happen if you give these patients oxygen? They will die. Why? Because when your respiratory system goes down, what happens to carbon dioxide level? Goes up, what happens to oxygen level? Goes down. So high carbon and low oxygen both stimulate respiratory system. But what this drug does, this decreases response to increased carbon dioxide. So whatever little breathing patient is having, that is dependent on water. Because now he cannot respond to high carbon dioxide. So whatever his respiratory rate is very low. Whatever little respiration is he having, that is dependent on what? Low oxygen. That is driving oxygen, means respiration. What if you give patient a normalized oxygen? What will happen to respiratory system? It will shut down. So any patient who on an overdose of heroin, morphine, whatever, and his respiratory system is down, will you give them oxygen or naloxone? Naloxone. Now what is naloxone? What is naloxone? It is antidote for morphine. Now antidotes you have to memorize. What is antidote for benzodiazepine? Flumazenil. What is antidote for heroin? Naloxone. Okay, in Dr. Rush, Rush drama serial, this they were talking about means someone where he was a big celebrity, he was using fentanyl patches, so he was taking an overdose of morphine. Okay, so he removed those patches and gave that patient naloxone. Okay, they now you see in TV serial also. It has minimal effect on heart, but it causes vasodilation. So if it causes vasodilation, it will cause also edema. So can you use them in head trauma? Because brain edema can cause herniation. Remember from CNS chapter it can cause herniation. Smooth muscle, longitudinal muscle relaxes and circular muscle constructs. What effect this will have on GI system? Longitudinal muscles have peristaltic movement. So will there be any peristaltic movement? No. Circular muscle is a sphincter. What will happen to sphincter? He will close. So patient will have what? Constipation. And what about cramping? Sometimes you have diarrhea. In diarrhea, what happens? Your colon is moving too much. So you have crampy type of abdominal pain. So can it be used for diarrhea? Yes, some diarrhea drugs have this because they will decrease peristalsis, they will decrease cause constipation, and they will decrease cramping pain. When you have diarrhea, your colon muscles contract too forcefully. You have crampy type of abdominal pain. They will cause constipation. They will also cause urinary retention because circular muscle constrict, longitudinal muscle relax. Circular muscles are what? Sphincter. So sphincters are closing means you cannot urinate. What will happen to biliary pressure? Because can gallbladder empty itself? Because circular muscles, all holes, all doors close. So biliary pressure will increase. So can you use this in acute cholecystitis? No, because you cannot use morphine acute cholecystitis except one drug that I will tell you which drug. Why? Because they will increase biliary pressure. They will cause more pain. And eye muscles we covered last time. Longitudinal radial muscles will relax, but circular muscles will constrict. When circular muscle constrict, what it causes in eyes? Meiosis. Okay, so it causes meiosis. Now, if there is an overdose of morphine, what is tried that we will look for? This is a anesthetic, so patient will be CNS depression, coma, pinpoint pupil, and respiratory depression. Okay, coma, pinpoint pupil, meiosis, respiratory depression. If you see this trial, that patient has an overdose of what? Yes, and Dr. Rush, and in this he diagnosed by this. He just came, looked at the eyes, pinpoint pupil, respiratory rate is low, and he's in coma. He said it is morphine overdose. But where is morphine? He removed his clothes. There were fentanyl patches. He removed those patches and gave patient what? Naloxone. So easy to. Now you know what it will cause: constipation, urine retention, and pinpoint pupil because longitudinal muscle relax and circular muscle constrict. It is also cough suppressant. Okay, independent. That job is independent of analgesia and respiratory depression. So most commonly, cancer patient. Sometimes their cancer metastasizes to bones and they have severe pain. And in that severe pain, which drug you use? Morphine. You cannot use simple analgesic. But it has cough suppressants. If you see some cough drugs, they will have dextromethorphan, something like that. That is also morphine class. That job is independent of analgesia and respiratory depression. So it causes nausea and vomiting. It also increases stomach. So it is a good drug to treat nausea and vomiting? No, it causes. And which two drugs were metabolized by glucourinidation? One was morphine, other was chloramphenicol. Remember? Remember from chapter morphine and chloramphenicol. And these same drugs will undergo enterohepatic circulation. I covered last time. Morphine, glucourinidation, other is what? Chloramphenicol. Anything that is glucourinated, that goes enterohepatic circulation. Means from through bile it will go to colon, small intestine, and it will be reabsorbed. Enterohepatic circulation. And you have to be very cautious in renal dysfunction. Why? Because some of it is also, look, anything that undergoes enterohepatic circulation. First it is glucourinated, Gluconeogen, now it will go to small intestine. Small intestine, from small intestine it will blood again, into blood again. When it enters blood again, how does it get gotten rid of? Through kidneys. You know, when you do not urinate for some time, your urine looks yellow. What is that yellow thing? Bilirubin. Why? Because bilirubin is conjugated, it will undergo the enterohepatic circulation. After that, it is again released by kidney. If someone has kidney problem, now you are using morphine. If too much morphine, it can cause respiratory depression and death. So you have to be very cautious in renal dysfunction. And here there is some table. Where is that? Okay, that is coming later on. So first let's study full agonist. Okay, mepridine. Mepridine, does mepridine cause meiosis? Why it doesn't cause meiosis but it causes tachycardia and no spasm in GI-UG bladder? Because it has anti-muscarinic. Anti-muscarinic is cholinergic factor. So means in acute cholecystitis, which drug you can use for pain? Mepridine, because there is no effect on colon, GI system, GU system, and gallbladder. Okay, but other drugs can you use in cholecystitis? No. And plus, does it cause meiosis? No, because it is anti-muscarinic. Anti-muscarinic drug. What is anti-muscarinic? I covered last time. Remember? Anti-muscarinic drug. They will cause meiosis or mydriasis. Mydriasis. Remember? Okay, if you go and revise this chapter. And this also has anti-muscarinic. And it is metabolized P450 system to what? Norepinephrine. Norepinephrine is a serotonin reuptake inhibitor. So means, and this can cause serotonin syndrome that I will cover in future chapters. Because it will cause serotonin, it will inhibit serotonin reuptake. There will be too much serotonin in the body, and this can cause what? Serotonin syndrome. That we will cover in depression chapter. Methadone. Have you heard about it? It is used in maintenance of opiate addict. Okay, I will explain later on how it is used. Codeine. Have you heard about it? It is used as cough suppressant, analgesia. You know, most cough drugs, if you see, they have little bit codeine. It is an analgesia, but is used in combination with another NSAIDs. So you know what are the. And then mixed agonist antagonist means at some receptor they are agonist, at other receptor they are antagonist. At mu receptor, what are they? Antagonist. So it can precipitate what? Withdrawal. What if someone is a heroin addict and you give them this drug? I have no problem because I am not a heroin addict. So I will have no withdrawal symptoms. You see withdrawal symptoms only in addicts. What if someone is coming, he is a heroin addict and morphine addict, and you give them nalbuphine or pentazocine? This will block receptors and it will create withdrawal symptoms. Now these are drugs that you need to know. Then what are antagonists? Naloxone, naltrexone, and methyl. If there is a overdose of morphine or heroin, which drug you use? What is antidote? Naloxone. And what is the naltrexone? Naloxone is used IV, but naltrexone is used orally and decreases craving in alcohol and opiate addiction. You know, so not only opiate but alcohol. If someone is addicted to alcohol, now he is craving for alcohol. He craves for it. So you can use naltrexone. Can you use naloxone for that? Naloxone is only for acute toxicity, acute overdose. Okay, naltrexone is for not for acute use. It is used orally to decrease craving. Look at these words. Methyl naltrexone treatment of opioid-induced constipation because does not cross blood-brain barrier and won't precipitate withdrawal. If someone, someone is using too much opiate, but what opiate is causing? Constipation. And some people have severe constipation. Is constipation good? No. In that case, you need some antidote. What is that antidote? Why we use this? Because this will not cross blood-brain barrier. If you use some other drug that can cross blood-brain barrier and precipitate what? Withdrawal symptoms. So it will treat only constipation. So you need to know these three drugs, antagonists. If there is a severe toxicity, what will be three things? I already told you. Pinpoint people, respiratory depression and coma. And if there's acute toxicity, what drugs you will use? IV, naloxone. And again, whenever there's some drug of abuse, what is sequence? First you become tolerant, then you become physically and psychologically dependent. Once you become physically dependent, now your body, not only mind, but your also body needs that. If you don't get that drug, what will happen? Withdrawal symptoms. So I told you alcohol withdrawal can kill you. What about heroin withdrawal? Can it kill? No. Heroin withdrawal cannot kill. You see, alcohol withdrawal is very bad. It can kill you because you have life-threatening fears. It can kill you. Heroin withdrawal cannot kill you, but it will do very, very bad things. What is the worst thing that it can do? It was making you, you know, it was making you what? Pain tolerant perception. It was decreasing perception. Now, when you suddenly stop heroin because morphine you are not getting, what will happen? But is there any pain? No pain. It is CNS originating. There's no pain. That's your brain is creating it. There's no pain, but because now you suddenly stop, so your body became more perceptive. Your brain is thinking that there's pain everywhere, and that CNS originating pain will be so severe he will do anything to get heroin, maybe steal, maybe kill. So is a heroin withdrawal life threatening? But it is bad because of CNS originating pain. And what other things you will see? Yawning, lacrimation, rhinorrhea, salivation, anxiety, sweating, and diarrhea. Especially whenever I see lacrimation, yawning, and some kind of pain, sweating, I see what is that? Heroin. Okay, so you should be able to diagnose acute toxicity, but also heroin withdrawal signs and symptoms. What are withdrawal signs and symptoms? Yawning is classical. Whenever I see in which other drug overdose, you can see lacrimation, rhinorrhea, salivation, sweating, and spasm or muscle cramps. Which other drug that we covered? I think we covered the last time. No, we did not cover. It is a acetylcholine esterase inhibitor. Remember organophosphate, insecticide poisoning, dumbbell. If we have time, we cover it today or next time. So, but then what is different here? Only different thing is what? Yawning and CNS originating pain. Otherwise, everything is same. But yawning and CNS originating pain. That is all. Opiate related drugs that have specific indication. One is loperamide, that is used for what? Diarrhea. Other dextromethorphan, that is used for cough. And codeine. Codeine is also used for what? Okay. And what is management of withdrawal? If someone has withdrawal symptoms, will you give patient heroin? No. You have to support clonidine. Clonidine is in a cholinergic chapter, adrenergic chapter. Then why we are giving methadone? Methadone is also from heroin. Methadone is that we call smooth tapering. It has a very long half-life, maybe 48 hours. 48 hours is how many days? 2 3 days. So you give one drug now, means one dose now for 2 3 days. Will he have symptoms? So now for 3 days, is he receiving any drug? Is he feeling anything? No. Then what I will do, it will take not just 1 or 2 days, 6 months or 1 year. I will slowly taper methadone. Okay, because now I'm giving him one dose, but after 3 doses, means I will keep that dose for maybe 3 4 weeks. After 3 4 weeks, I will come from 60 mg to 40 mg or 50 mg. Again, after 2 months, I will come to, so slowly, after 1 year, I can stop it and patient can get rid of that addiction. Now you understand it? Why we are using methadone? Because it has a long half-life and we can slowly taper it. But this is possible only in some specific addict hospitals. There are hospitals in USA for that. Must be in every country. Okay. And this is also very important. All contraindications and cautious for opioid. Head injuries. It causes vasodilation. So can you use them? Because it will increase intracranial pressure. It causes in any kind of pulmonary dysfunction. Because it causes respiratory depression. So can you use it? But in one pulmonary problem you can use it. What is that? Pulmonary edema. We use it. If patient has severe pulmonary edema, what is treatment? Pulmonary edema means lungs are full of water. So you will use a diuretic to get rid of water. That is loop diuretic. Okay. Pulmonary treatment you can write loop diuretic. Also, if lungs are full of water, patient will have difficulty breathing and oxygen problem. So you will give patient oxygen. Okay. What other thing you can use? Is dyspnea type of pain? You know, dyspnea, difficulty breathing is a kind of pain, bad feeling. In dyspnea, which drug you will use? Means this is a kind of pain. So when patient has difficulty breathing, means patient becomes anxious. So because dyspnea is a special type of pain, it's a type of pain. So which drug we will use here? And patient has severe dyspnea, means severe pain. In kind of severe pain, which drug we use? Morphine. So that is management of pulmonary edema: oxygen, loop diuretic, and morphine. So in other pulmonary problems, can you use morphine? No. Okay. So what about a hepatic and renal dysfunction? You know where it is conjugated? Liver. After conjugation, it undergoes enterohepatic circulation and where it gets excreted? Through kidney. So in both cases, also you avoid it. And adrenal and thyroid deficiencies, because you have exaggerated repulse, it is avoided. What about pregnancy? You cannot, because it will cause neonatal depression or dependence. In a sometimes a heroin addict females, because they sell their body for heroin and they get pregnant, and when their babies are born, babies are dependent on what? Their babies are also heroin addict, because through uterus baby gets it. And except if someone is pregnant and you have to, that baby will become dependent if mother is a heroin addict. What if during pregnancy patient has severe pain? I use only once. Then it can still cause neonatal depression. But during pregnancy you can use one drug. What is that? Mepridine. In cholecystitis you can also use one heroin morphine drug. What is that? Mepridine. Okay. In all pulmonary cases you will never use morphine except one. What is that? Okay. Got it? It's very easy. Now these, is this too much deep? We still can study for 1 hour and stop at 9 p.m. Okay, is this too much deep that we are teaching you? We are very super. What at least you as a doctor you should know what is morphine, what are its uses, what are contraindications, How will I diagnose overdose? I will diagnose withdrawal. How I will treat overdose? Give naloxone. How I will treat addiction? Supporter, methadone and clonidine. Okay, so these things you should know. This is ABC. So I think we can have 10-minute break after that. Okay, we can do one more chapter. If I don't have time, we can cover one chapter and the other chapter then I can cover next time. Okay, and once I finish adrenergic and cholinergic chapter, then I will teach cardiovascular. And before I teach cardiovascular, you should know cholinergic, adrenergic, and autonomic nervous system. We are have study for 3 hours, but we are still feel tired. But what if we study for 7 hours continuously? That was not a wise idea. Okay, so I'm started from slide number 19, adrenergic pharmacology. Okay, cholinergic maybe I do next time. Do you have energy to go for 1.5 or 2 hours more, or 1 hour is okay? Ah, okay, okay. So 1 hour is okay. Okay, okay. So next time I will maybe instead of if we do little less now and we can have 3 hours one more class. Okay, so it will be more convenient. Where this already covered. Remember when it was my I think my first lecture. But at that time I was not so confident and you were also new. So we had some and this is very one of the very important. Adrenergic pharmacology, it is sympathetic or parasympathetic? Sympathetic. Cholinergic is parasympathetic. So first you should know how adrenaline is made. You see, it is made from tyrosine. Tyrosine hydroxylase. It is covered with dopamine. From dopamine, what you get? Norepinephrine. But do you need to know all these enzymes? No, because I already told you that anything that has a role in diagnosis, pharmacology, management, you need to know. But these enzymes have no such big role. So why you need to know these? Okay. So means you just need to know that tyrosine makes norepinephrine. Once it is made, it is stored in vesicles. Now, why it should be stored in vesicles? Because otherwise it will be destroyed by which enzyme? MAO. Okay, so you see once it is stored when there is action potential it is released. After released, on which receptor it acts? Alpha and beta. Remember from last lecture what are receptors for means adrenaline or epinephrine or norepinephrine? They were alpha and beta. These are receptors for sympathetic system. So after it means it is a neurotransmitter. It has to work quickly. After working quickly, it is either metabolized by CMT or recycled, reuptaken, recycled. When it is recycled, it is in mobile pool. In mobile pool, either it is destroyed or it is stored. So means now you also have alpha 2 receptor. What is job alpha 2 receptor? It is like a negator feedback effect. When alpha 2 receptors are stimulated, they block. You see, it is negative sign. Release of norepinephrine. So why you need to know about this figure? Because there are drugs that work here. You see, what is methyl p-tyrosine at position 1? That belongs to tyrosine hydroxylase, but this is no longer used. This is was used in olden days in research. So at position 1, we have a drug, but we no longer use it. But MAO are very good drugs. What will you have if you block MAO? Will you be able to metabolize norepinephrine? Not. Then there's too much norepinephrine means what will happen to sympathetic system? Stimulated. When you are in sympathetic mode, you are in depression or stimulated. You are stimulated. So MO inhibitors are used for as these are antidepressors and releasers. What will be their job? They will release norepinephrine from mobile pool. They also will stimulate means sympathetic system. So reuptake blockers, they will block reuptake of norepinephrine. If you block the reuptake of norepinephrine, what will happen to norepinephrine over here? It will increase. So sympathetic system will be increased. Alpha 2 agonist and antagonist at means over here we alpha receptor drugs and over here beta drugs. And what is job of reserpine? Means at position 8. At position 5 alpha drugs, at position 8 we have beta drugs. What is reserpine? Position 6. If you use reserpine, what it will do to these vesicles? Destroy. If these vesicles are destroyed, is there any norepinephrine? But other neurotransmitters such as serotonin and are they are also stored in these vesicles. So if these vesicles are gone, means norepinephrine is gone, serotonin is gone. So what patient will feel? Severe depression. So reserpine is no longer used because of which side effect? So much depression, so some patient even committed suicide. Okay, gonethadine is also old drug that is reuptake blocker but no longer used. And agonist and blockers of alpha 1 and beta 1 receptors that is position 8. Now you see which drugs at position 1, 6 and 7. Are we using these drugs nowadays? They are gone like black and white TV. We no longer use them. So which drugs are direct actors? Yes, that directly going to stimulate alpha and beta. Other drugs are indirect. What are other drugs indirect? 2, 3, 4. All these drugs are what? Indirect actors. So if you means if you stimulate alpha 2 agonist antagonist, what will happen? Norepinephrine release, it will go down. So this is very important figure that you need to know. This is all explanation that I just explained. Now you have to understand. Okay, this table is very important, and once you know, we covered the sympathetic system last time, so we know what's whenever there is a smooth muscle, what receptors act? Alpha 1, and they will cause smooth muscle contraction or contraction. So an eyes, when you are sympathetic mode, what you have meiosis or mydriasis? In sympathetic mode you have meiosis. When you are fighting, your eyes need more light or less light. So you have mydriasis. So alpha 1 will stimulate radial smooth muscles, it will cause mydriasis. When you are sympathetic mode, what happens to your blood pressure? Increases. So TPR that will come later on. Let's go very quickly. It will cause vasoconstriction, arterioles and veins. When you are sympathetic mode, okay, do you want to pee? Yeah, if you are running to save your life from a terrorist, you stop and try to pee, you will die. So you should have urinary retention. Okay, so you see bladder trigonal sphincter, they will contract, you will have urinary retention. You will also have fecal retention. And sex is something different. Mostly either you have sympathetic mode more active or parasympathetic, but with sex you have both sympathetic and parasympathetic active. Why? Because for ejaculation, smooth muscle must contract peristaltic movement. For smooth muscle contraction, peristaltic movement, you need which system? Sympathetic. So ejaculation is job of sympathetic system. Okay, but what about erection? For erection, blood vessels should dilate. Sympathetic system dilates or vasoconstricts blood vessels. So for erection, what you need? Sympathetic or parasympathetic? Parasympathetic. So erection is job of parasympathetic. Okay, and ejaculation, what you call it, climax, that is job of which system? Sympathetic. So when you are sympathetic mode, you need more glucose or less glucose. So what should happen to glycogen? It should be broken down. And kidney Remember, it decreases renin. I will explain this later on. Alpha 2. Alpha 2 platelet aggregation and norepinephrine decrease. That is not much important, but pancreas decrease insulin. So kidney decreases renin and in pancreas decrease insulin. I will explain first. Let me explain this thing. Where you have beta 1 receptors in only two organs. What are two organs? Heart and kidney. Remember from last lecture what was sympathetic system doing to the heart? Increasing heart rate, increasing conduction, increasing force of contraction. You see conduction, force of contraction and heart rate. But parasympathetic mode, it was controlling only heart rate. So beta 1 receptor you find only in where? In the heart. AV node, atrial ventricular muscle pulmonary system. Where else you find beta 1 receptors? And what it releases? Renal. Now, do you see any contraindication here? Beta 1 increases renal release and alpha 1 decreases. It is same sympathetic system, but one increases, other decreases. Why? Because look, which receptors are more sensitive, beta or alpha? That is next slide. Beta. So initially, when you are sympathetic mode, you want your heart rate to increase. You want your blood pressure to increase. So heart rate increases, blood pressure increases by what? Renin. When you are still more stimulated, your blood pressure should increase even more. Then after beta, which receptor will be activated? Alpha 1. So means now your blood pressure will go shooting up. If blood pressure goes too high, what will happen to you? You will die. So there should be safety valve. What is that safety valve? Alpha 1. Because at the same time it will cause vasoconstriction, increase blood pressure. But at the same time it will control so that blood pressure should not go very high. So it will decrease renal. Now you see any contraindication in this system? All this is to keep the system within a range, balanced. Your blood pressure should increase, your heart rate should increase, but blood pressure should not go sky high, should not skyrocket, because otherwise you will be dead. Now you understand this? Okay. So mostly, where are alpha 1 receptors? In all smooth muscle. Okay. And where are beta 1 receptors? Only in heart. But alpha 1 and beta 1, you also see one other organ, kidney. Beta 1 increases renal release and alpha 1 decreases. Why? They have to keep blood pressure within a range. Got this? Now, where are beta 2 receptors? All other organs that you can think of. Blood vessels, uterus, bronchioles, skeletal muscle, liver, pancreas. You see, in skeletal muscle, liver, what it does? Increases glycogenolysis. Why? Yeah, when you are fight in flight mode, you need what? Glucose. So it is beta 2 because beta 1 are only in mostly in heart. So you need glucose. But to need glucose, to be able to use glucose, you need what? Insulin. So beta 2 also increases insulin secretion. But are glycogen stores unlimited? Not unlimited. So means glycogen goes up, insulin goes up, but after some time glycogen is depleted. Now glucose is going down. Then what you should do to insulin? We have to stop it. And who will stop insulin secretion? If beta 1 is increasing, then what is alpha 2 is doing? Because if we don't stop, you see beta 2 receptors are more sensitive. They are activated first. When we are in sympathetic mode for too long, we should stop insulin at some point. Because if we don't stop insulin, what will happen? Hypoglycemia and patient can die. Okay, now you understand, is this a contraindication in this? When you are in fight and flight mode, what happens to you need more oxygen or less oxygen? So you bronchioles should dilate or constrict? Dilate. What about uterus? You know, sometimes all pregnant females are, maybe they meet some accident, maybe they are angry. They have a fight with their husband. Okay. So in that means in that pregnant female is in which mode? Sympathetic. So what should happen to uterus? Relax. Why? What if it contracts? Baby will be lost, and baby is the future of human race. So nature wants human race to be safe. Means what kind of trauma is there? What kind of accident? What kind of fight with husband? Baby is safe. Why? Because uterus relaxes. Now in this one system, in how many ways nature is trying to save humanity or human race? What are those? There's a safety valve so that your blood pressure doesn't go too high. Renin is going down. There's a safety valve so that insulin should not go too high and you should not develop hypoglycemia. And there's a safety valve, you see, for your baby to be safe in the womb. And blood vessels, beta 2, they all cause vasodilation. Because alpha 1 cause vasoconstriction, then beta 2 cause vasodilation. Why? Again, blood pressure should not shoot very high. Now you understand this figure? First you understand this table. First you need to understand what sympathetic system does. If you know sympathetic system, then this is very easy. Where alpha 1 receptor, where alpha 2 receptor, where beta 1 receptor, where beta 2 receptor. Now you see one thing here. Are beta 2 receptors innervated? Not innervated. Not innervated. So beta 2 receptors will be activated by epinephrine or norepinephrine. Last lecture. Norepinephrine was neurotransmitter. So it will activate only receptors that are innervated. But these receptors are not innervated. Means they will be activated by which? Epinephrine. Because epinephrine was a hormone, so it was in blood. Got this? So another is D1 receptor. Where are they? Renal, mesenteric and coronary vasculature. Why you need to know this? Because you know, when a patient is in shock and there's very little blood in body, where that blood should go? What is the most important organ to save? Brain. What will happen to blood supply to kidney, heart? It will stop. Because you should see any shock patient, his hands will be cold, clammy. Why? Because when you are shocked going to die, is it important to save hand or brain? Brain. So arteries or veins in the hand will vasoconstrict. At the same time, vessels in colon, because you don't need to digest. Heart and kidney will stop. Okay, your brain will survive, but without a colon, kidney and heart, will you survive? So what we do, sometimes we need to increase blood supply to these important organs, because if we want the patient to survive, these organs are also very important. In that case, which drug we can use? We use a drug that will cause vasodilation in activate D1 receptors and cause vasodilation in these receptors and these organs. And that drug is what? Remember? Dopamine. But will you use an excessive dose of dopamine or just a small dose? Why? Because if you increase doses, which receptors will be activated? Alpha 1. You see, increasing doses. Then what will happen? When you stimulate alpha receptor, now it will cause vasodilation or vasoconstriction. So now you are going to kill patient. So sometimes, you know, nurses or doctors who don't have enough knowledge, they say patient is going to die. So we need to give as much dopamine as possible. But is it okay? No, never. Medicine is science, but it's also art. Art means when you will use, how much dose you will use. Too much dose can kill patient. And now this shows beta receptors are more sensitive to activators than alpha receptors. We already know this thing. At low doses, which receptors will be predominant? At higher doses, which receptors will be predominant? Alpha. So higher doses you have to avoid. Now you understand this figure and this concept, this table. Okay. You have to understand alpha 1 receptor, alpha 2, beta 1 and beta 2. Now we use drugs that will directly act on alpha receptor. Any drug that directly acts on alpha receptors, what it will cause? Vasoconstriction. When it causes vasoconstriction, what happens to TPR and BP? And when blood pressure increases, remember from last lecture, by reflex, what it will cause? So you see, these spacings are become wider. So they can give you tracings like that. Is there any change in pulse pressure? Well, pulse pressure is job of beta 2. So not job alpha 1. Okay. Systemically, it will increase blood pressure via vasoconstriction. And by reflex, it can cause bradycardia. Okay. Cardiac output may be down, but it is offset by venous return. So it has no change in cardiac output. So forget about it. What are drugs that we can use? Methoxamine is no longer used. It is an old black and white TV because sometimes patients have tachycardia, arrhythmia. So what drugs in olden days we used to give? Methoxamine. Why? Because it will cause vasoconstriction. By reflex, it will slow heart. So was methoxamine directly causing decreasing heart rate? It was indirect drug. Nowadays we will cover it in arrhythmia chapter. We have drugs that act directly. So we use now better drugs. Then what are phenylpheniramine used for? Remember, when you have a cold, your nose is runny, stuffy. Why your nose is runny? Because blood vessels dilate and they become leaky. Now you want, if they become dilated, leaky, what you should do to blood vessels? You cause vasoconstriction. For that, which receptor you will stimulate? Alpha 1. Okay, that's one using nasal decongestant. If you see one other drug that is not written here, xylometazoline. Have you heard about it? If you have ever used a nasal decongestant, it's xylo, XALOMET, metazolone, something like that. If you go xylometazolone, zolone or zolone, I don't remember. That is also used in the nasal decongestant. Then what will be its mechanism? Alpha 1 because it must cause vasoconstriction. Another use, if you remember from last time, ophthalmologic use, what will be? If you stimulate sympathetic system, you will have cycloplegia or just mydriasis without cycloplegia. Mydriasis without cycloplegia. If mydriasis with cycloplegia, what will be that drug? Muscarinic antagonist. Last time. Okay, I think you don't review that. Okay, muscarinic antagonist, AIM antagonist. Remember? So sometimes doctors just want to cause mydriasis but no cycloplegia. Then they use alpha 1 agonist. Alpha 2 agonist. One is clonidine, other is methyl dopa. Clonidine we already covered just now. It was used in which system? Heroin or morphine addict supportive system. Because when patient don't get heroin, their sympathetic system becomes activated. Their blood pressure goes high. So we have to block their sympathetic system. So one drug we will use clonidine, others methyl dopa. Methyl dopa is a drug of choice to treat hypertension in pregnancy. It is drug of choice to treat hypertension in pregnancy. Do you have audio of that first lecture I took? Our video? I already covered these. So this is just review. So I will try to go faster. If you want to study detail, you can go back and watch it. Okay, but this is very important because before I cover, without this I cannot cover cardiovascular system. What will beta agonist will do? If you stimulate beta 1 receptor, what it will cause? Beta 1 receptor, where they were? Heart will increase heart rate, stroke volume, because force of contraction, cardiac output. But it will also increase pulse pressure. I told you pulse pressure is the job of beta receptor, not alpha receptor. Heart rate will increase, but beta 2 will also at the same time cause what? Vasodilation. So what will happen to TPR and blood pressure? You see, blood pressure and TPR decreasing, but heart rate is increasing. Cardiac output, stroke volume is increasing. So pulse pressure is increasing. Got this? You see, pulse pressure is difference between systolic and diastolic. So systemically, they will increase increase heart rate and decrease blood pressure. So what are drugs that we can use? Iso means equal. So isoproterenol equally activates beta 1 and beta 2. So what are its uses nowadays? Nowadays we became more specific. So we will use a drug that will activate either beta 1 or beta 2. Okay, you see in congestive heart failure, heart is very weak. So you want to give a push to the heart. So which receptor you want to stimulate? So why don't you use dobutamine? Why use isoproterenol? It has some use in emergencies, but not that much. And in asthma, what you have broncho. So you want to cause bronchodilation. Which receptors you want to stimulate? In in bronchi, which receptors you have? Beta 2. So you why don't you use salmeterol, albuterol, terbutaline? You know, sometimes patient is going to have premature labor and baby will be premature. So you want to delay that labor or delivery. Which receptors you will stimulate? Beta 2. Okay, again retrodrin. Because beta 1 receptors are only in heart and which one other organ? Kidney. Everywhere else, which receptors you have? Beta 2. Metabolism, glycogenolysis, lipolysis, you have beta 2. So beta 2 is associated with metabolism. Now you understand this? So what are uses of dopamine? What are uses of salmeterol, albuterol, isoproterenol? Do we have uses it now? For bronchospasm, which drug you will prefer? Beta 2. For heart block or bradycardia, which drug you will use? Dobutamine. So anyway, when they ask side effect, what will be there? If you give isoproterenol, they can cause angina and arrhythmia and flushing. Why angina and arrhythmia? Because you are stimulating which receptor? Why flushing? You are stimulating which receptor? Beta 2. Because if you stimulate beta receptor, blood vessels will vasodilate and you will get more blood. So you will have flushing. So norepinephrine. Norepinephrine was a transmitter or neurotransmitter? Or it was a hormone or neurotransmitter? So it will means activate receptors that are innervated. And which receptors was not innervated? If you go to the first table, which receptor was not innervated? Beta 2. So here you see in norepinephrine you see alpha 1, alpha 2, beta 1. Do you see beta 2 here? So it has no effect on beta 2. So when you see this at this point we give norepinephrine, so it will stimulate alpha receptor, blood pressure will go up. It will stimulate beta 1 receptor. Initially heart rate will go up, but later on when blood pressure goes up by reflex, it can cause what? Bradycardia. So you now understand all this figure. This is very, I already told you, any figure like this in Kaplan book, it is very important. Now you see epinephrine. Epinephrine will activate every receptor. Alpha 1, alpha 2, beta 1 and beta 2. So low dose epinephrine. At low dose, which receptors are active? Which receptors are more sensitive? See, at low dose you see only beta activity. Do you see an alpha activity? So medium dose is not tested, but a high dose is tested. If you see epinephrine tracings and then you see high dose epinephrine, it is exactly same. Because at a high dose, which receptors are more active? Alpha, beta 1. Then what about beta 2 receptor at high dose? Where are they in this figure? Because at high dose, which receptors will be predominant? Alpha 1. What about beta 2? They are masked or hidden. They are there activated, but they are masked or hidden. Then if you want to see, this is, can you tell me from this tracing whether it is epinephrine or norepinephrine? Because they look exactly similar. How, okay, you cannot tell this from this figure. How will you find out then? What will happen if I block this alpha receptor? Now you are masking which receptors? Unmasking which receptors? So now patient will have hypertension or hypotension. If you block alpha receptors, you are left with only beta 1 and beta 2. When you are only beta 1 and beta 2, you will have things like that. Then from hypertension, patient will go into what? Hypotension. And this is tested. We call it epinephrine reversal. When sometimes, sometimes you give too much dose of epinephrine. Now you need to reverse it. Where now it is increasing blood pressure. How will you reverse it? You will give which drug? Alpha blocker. Okay. So alpha 1 job will, what are beta 2 specific effect? It will dilate bronchioles, it will dilate uterus, it will dilate blood vessels. And beta 2 was also associated with metabolism. It will increase glycogenolysis, gluconeogenesis, and mobilization lipolysis. So all glycogenolysis, gluconeogenesis, lipolysis, mobilization, and the use of fat. What we call this? We simply call it metabolism. So see, beta 1 are only in heart. Everywhere else, what kind of receptors we have? Beta 2. Now, how will you differentiate high dose of epinephrine versus norepinephrine? Which receptors you will block? Alpha 1. Then it will go from hypertension to hypotension. Hypertension was due to predominant alpha 1 tone, and hypotension was unmasking of beta 2 receptors. So, use of norepinephrine and epinephrine. For asthma, which receptors you want to stimulate? Beta 2. So, will you use epinephrine or albuterol? Albuterol. So, means pharmacologically you can use epinephrine, but which drug you will prefer? Beta 2 stimulator, that is albuterol. For hypotension, you can use epinephrine because it will cause vasoconstriction, increase blood pressure. But in reality, for hypotension, what we use? No, we use IV fluid. When your blood pressure goes down, okay, theoretically, but it is better to produce, okay. Now, what if patient dehydrated already because of diarrhea, vomiting? Then you need to give IV fluid. So, okay, adjunct to local anesthetic. You remember we covered just local anesthetic because we have to cause vasoconstriction. Otherwise, local anesthetic will spread to body and shut down your heart and brain. So, which drug you can use? Epinephrine. But with cocaine, will you use epinephrine? No, because cocaine intrinsically has vasoconstricting activity. For cardiac arrest, which drug you will prefer? Which drug has longer activity? Epinephrine. Because norepinephrine has very short half-life. So sometimes if you have seen movies, sometimes heart is not working, they give injection here. And heart, what that injection contains? Why? Because epinephrine has beta 1 activity. Okay, you now need to stimulate beta 1 receptor. But which drug will stimulate beta 1 receptor? Quickly. Dobutamine or epinephrine? That is epinephrine. Dobutamine will work slowly. This is an emergency. Okay. For anaphylaxis, best drug is only epinephrine. Drug of choice, life-saving. What is anaphylaxis shock? When you are allergic to bee sting and bee stings you. You are stung by bee, or you are allergic to penicillin, someone gives you penicillin injection. In that anaphylaxis, that you used to be immunology, what happens? Your blood vessels dilate all over body. So if all over body blood vessels dilate, it will cause shock. At the same time, you have bronchoconstriction, wheezing, you cannot breathe. Now you need to do two things. You need to cause vasoconstriction, stimulate alpha 1 receptor. You need to cause bronchodilation. There is only one drug that can do that. What is that? They are epinephrine by stimulating beta 2 receptor. Can you use albuterol here? No, albuterol will cause bronchodilation, but it will not treat shock. So you have two things to treat. For asthma, preferred drug that is albuterol. For shock, use it. Anaphylaxis, use a drug. You can only use one thing, that is epinephrine only. Hypotension, you use IV fluid first. Adjunct to local anesthetic, it is mostly epinephrine used. Cardiac arrest, you can use epinephrine, but mostly it is epinephrine. For asthma, why they are writing epinephrine? There for asthma, you need to cause bronchodilation. What is that drug? That drug is what? Beta 2. But does norepinephrine has beta 2 activity? No, because norepinephrine is neurotransmitter. It activates the receptors that are only innervated. So now indirect acting, those were direct acting. Indirect acting, what were drugs? Releasers. How were releasers acting? You know the first figure in this chapter. The releasers were displacing norepinephrine from mobile pool. So what interaction they will have with MAO inhibitor? What was job of MAO enzyme? It was breaking down norepinephrine. If you use a MAO inhibitor, will you break down norepinephrine in mobile pool? In mobile pool, there will be too much norepinephrine. At the same time, if you give a releaser, what it will do? It will release all that norepinephrine from mobile pool. And what will happen to your blood pressure? Shoot up. And patient can die. And one example is MAO inhibitor. What was used? Depression. You know, MAO inhibitor, because it blocks, if you use MAO inhibitor, will you be able to metabolize norepinephrine? Norepinephrine will increase. When norepinephrine increases, what happens to sympathetic system? So sympathetic system is stimulated. Depression patient, sympathetic system is low. So we need to increase sympathetic system. Now, if you use MAO inhibitor, means sympathetic system, everything looks bright. Previously, everything was dark, hopeless. Now everything looks bright. When you give someone an MAO inhibitor, now he is out of depression. What is the first thing they will do? Go enjoy with their girlfriend. Go to a party. In a party in USA, what they drink? Pizza. Pizza has cheese and red wine. And red wine has what? Tyranny. Not white wine, but red wine. So normally, when you drink red wine or eat cheese, that has tyramine. But does that tyramine reach our blood? No. Why? Because that tyramine is metabolized by MAO in gut and liver. Otherwise, if there is no MAO in gut and liver, what would happen? Every time we drink red wine and cheese, our blood pressure goes very high. So then will you be able to eat pizza? Pizza business will go down. So what nature did, nature gave us MAO in gut and liver. But now that patient is using MAO inhibitor. Now will that tyramine be metabolized by MAO in gut and liver? What will happen to that tyramine? It will reach our body. In our body, there's already too much norepinephrine because that patient is using what? MAO inhibitor. Now what will happen to that norepinephrine? All of that norepinephrine, because tyramine is a releaser, will come out, what will happen to blood pressure? it will shoot up. So whenever you are giving someone amino inhibitor, what counseling will be you give to him? Please don't drink red wine and don't eat cheese. Don't use cheese. Don't eat pizza, something that has cheese. Okay? If you don't, what will happen to them? And this is highly tested hypertensive crisis drug interaction. So tyramine is a releaser amino inhibitor. Okay? Amphetamine. It is used in ADHD, attention deficit hyperactive disease, narcolepsy. You know what narcolepsy is? Do you know what it is? I am teaching you. Suddenly I am snoring, sleeping and snoring. You are walking on the road, you suddenly fall asleep. Okay, narco means dead, lepsy means sleep. Is it good? Okay, so it's very bad. So you are driving, suddenly you fall asleep on your wheel. So in that case, you need to stimulate your brain. And ADHD, I will explain why it is ADHD in behavioral science. So in that you need to use it as a stimulant because it will centrally release serotonin, norepinephrine and dopamine, all hormones. So amphetamine is a releaser. Ephedrine is also a releaser. Ephedrine is used in cold medication. But ephedrine is tightly regulated. Amphetamine is a tightly what amphetamine it is called in USA. Have you seen that Breaking Bad? What they producing? Methamphetamine. That is a type of amphetamine. Why? Because these are psychostimulants and all psychostimulants can be abused. Ephedrine is also very tightly regulated. Why it is used in cold medication? Because it will cause release of norepinephrine that will cause vasoconstriction. Then why ephedrine is also tightly regulated? Because it is a drug of abuse like heroin. You know, sometimes they dilute heroin. It is pure, they dilute because as it goes into market, dilute, they will get more money for it. And what thing they can use to dilute it? Ephedrine. So just like cocaine, remember why cocaine is a drug of abuse? Because it is a reuptake inhibitor. It inhibits reuptake of what? Every neurotransmitter, not only norepinephrine, dopamine, and serotonin. And any drugs that increase dopamine, norepinephrine, serotonin level, they can be used as a drug of abuse. That can be amphetamine, ephedrine, and cocaine, even tricyclic antidepressant. MAO means all they stimulate means your brain. MAO type A, MAO type B. MAO type B is only in brain that metabolizes dopamine. MAO type A is everywhere, mainly liver, but anywhere it metabolizes norepinephrine, serotonin, and tyramine. And indirect acting, forget about this is not that much important. So now last two topics I can cover it in 20 minutes. So can you tolerate me for 20 minutes more? Okay. I already covered it. This is just review. Where before I start cardiovascular, you must know this chapter. So otherwise I can't cover that. So alpha receptors. What alpha receptors do? They cause vasoconstriction. So as they cause vasoconstriction means they no alpha receptor blockers. If you block alpha receptors, what will happen? Vasodilation. What will happen to blood pressure? When you have blood pressure goes down, what it will cause? Reflex tachycardia. And will kidneys get enough blood? So kidney will secrete what? Renin angiotensin system. So what will happen? Salt and water tension. So alpha, any drug that causes vasodilation decreases PPR. It will have two side effects. Not only alpha blocker, but when we cover antihypertensive drugs. So what are those two side effects that we need to memorize it for every drug that will decrease PPR? One is reflex tachycardia, other is salt and water retention. So what are uses? Hypertension, Remember pheochromocytoma from pathology? What was pheochromocytoma? Tumor in medulla that secrete what? Norepinephrine. Okay, remember endocrine pathology. So if there's a tumor that's secreting norepinephrine, epinephrine, what will happen to blood pressure? Increase, because epinephrine, norepinephrine will stimulate alpha receptors. In that case, you will use a non-selective alpha blocker or selective. Non-selective means non-competitive. Okay, I am coming to that later on. BPH, we already covered BPH in pathology. In BPH, what happens to prostate? It becomes enlarged. So urination is blocked. In that case, we need to open sphincter as much as possible. And sphincter has smooth muscle, and smooth muscle has which receptors? Alpha 1. So if you block alpha 1 receptors, what will happen to sphincter? It will open. And this will help with the urination or with widening. Okay. Now think, alpha 1 blocker can be used for hypertension and can be used for BPH. So mostly, what if I tell you, let's kill two birds with one stone? Means treat two diseases with one drug. What if some patient has hypertension plus BPH? Which drug you will prefer? Blocker. Because alpha 1 blocker not only treat hypertension, but it will also take care of what? BPH. You now understand it? Okay. So again, you have non-selective drugs. Non-selective means they will block both alpha 1 and alpha 2. Then you have selective alpha blockers. They will block only alpha 1. How will you remember that? Any drug that is Zosyn, Prazosin, Doxazosin. Zosin means it is alpha 1 blocker. Osin, Tamsulosin. Prazosin, Doxazosin, Terazosin was used for hypertension. And Tamsulosin, I think it is used for BPH. These are selective. But in pheochromocytoma, you need to use a selective or non-selective. Again, use it to non-selective. That will block both alpha 1 alpha 2. But that has to be competitive, non-competitive. In pheochromocytoma, we use a drug that will be competitive, non-competitive. Why? Because in pheochromocytoma, what is the level of epinephrine, norepinephrine? High or low? Very, very high. So, you see, competitive inhibition can be reversed. If you are using the competitive inhibitor, epinephrine, norepinephrine is very high, it can be reversed. But if you are using non-competitive phenolphthalein, can it be reversed? Whatever levels, how much higher levels of epinephrine, norepinephrine are, it cannot be reversed. So in pheochromocytoma, you will use a non-selective, but also non-competitive. Understand this? Non-selective plus non-competitive. Okay. And then selective alpha 1 blocker. One is yohimbine. It is used in hypotension impotence, but yohimbine is very old drug. Nowadays we don't use it. For postural hypotension, we have better drugs. For impotence, we have better drugs such as Viagra. So why will you use yohimbine? No longer used. But mirtazapine is used as an antidepressant because it is a selective alpha 2 blocker. Remember, let's go to first page. If you stimulate alpha 2 receptor, what happens to norepinephrine release? Goes down. If you block alpha 2 receptor, what will happen to norepinephrine? Increase. If norepinephrine goes up, means sympathetic system goes up, so it will treat what? It will treat depression. So mirtazapine is a very good drug for depression. Now this beta blocker is very important. It will take just 10-15 minutes. But for this I want you to be really fresh. So can we cover it next time? Because this is very important. Or if you have old lectures, you can look at it, then I can review it very fast. What do you want? Review it now? Finish it now? Because this is very important. Beta blockers are really very important drugs. So we can finish it next time. Okay? When next time you come, I first finish this beta blocker, then cover later on chapters of CNS, then I cover cholinergic, and next time then I will cover cardiovascular. Yeah, before I cover cardiovascular, you must master autonomic nerves. And let me again emphasize it. Autonomic nervous system is the most important chapter in pharmacology. Okay, it is most important. So you must master it. Is it difficult or easy? USMLE is all about concept. Okay, so these are just 3-4 slides that I will cover when you are next time in your fresh. Okay, so see you next time.